Acute respiratory distress syndrome, or ARDS, is a condition where there's inflammation throughout the lungs, leading to pulmonary edema. The main site of injury in ARDS is the alveolar capillary membrane. Now, any damage to the alveolar epithelium or the capillary endothelium increases the permeability of the alveolar capillary membrane, causing fluid to move into the alveoli. Oxygen and carbon dioxide have to travel across this fluid, so it acts as a barrier against normal gas exchange. The fluid also dilutes out the surfactant molecules coating the alveoli, and as a result, the alveoli are less able to remain open and compliant, so they become stiff. If the injury continues, the alveoli eventually collapse. Now, the pulmonary edema from ARDS causes the same problems as pulmonary edema from congestive heart failure. But because the triggering events are different, the term non-cardiogenic pulmonary edema is often used for ARDS. Now, ARDS is not a primary lung disease. Rather, it arises as a complication of a systemic injury that causes widespread inflammation, which results in damage to the alveolar capillary membranes within the lung. The most common underlying systemic cause of ARDS is sepsis, which causes systemic inflammation in response to an infection. But other injuries include trauma, severe burns, near drowning, disseminated intravascular coagulation, or DIC, acute pancreatitis, massive blood transfusions, aspiration of gastric contents, and toxic smoke inhalation. The list basically includes any serious trauma that directly or indirectly affects the entire body. So, as you would guess, individuals with ARDS are very sick and have severe shortness of breath, tachypnea, hypoxemia, and diffuse crackles on auscultation of the chest. At that point, it's important to look for an underlying cause, like pneumonia, urinary tract infection, or an infected intravenous line, all of which might result in sepsis. Other clues might include epigastric abdominal pain radiating to the back, along with a history of alcohol binge or gallstones, which indicate acute pancreatitis. It's equally important to make sure that the signs of pulmonary edema are not due to heart failure. An elevated jugular venous pressure, an S3 heart sound, orthopnea, and paroxysmal nocturnal dyspnea all clue towards heart failure, and these findings are not present in ARDS. ARDS is clinically diagnosed by fulfilling the following criteria. The symptoms developed within 1 week of the suspected injury. Chest x-ray shows diffuse bilateral opacities. The symptoms are not fully explained by congestive heart failure. And the ratio of the partial pressure of oxygen in the arteries, or PaO2, to the fraction of inspired oxygen, or FiO2, is less than 300 millimeters of mercury. The first two criteria are usually straightforward. For criteria 3, there are some ways to help objectively determine whether congestive heart failure is contributing to the pulmonary edema. First, you can measure the serum brain natriuretic peptide, or BNP levels, which are elevated in congestive heart failure. Second, you can do an echocardiogram, which would show an ejection fraction below 55% in systolic heart failure, and abnormal relaxation of the myocardium in diastolic heart failure. Third, you can insert a Swan-Ganz catheter and measure the pulmonary capillary wedge, or PCWP, which is a reflection of the pulmonary venous or the left arterial pressure. The PCWP is increased in heart failure, typically over 18 millimeters of mercury. The PCWP increases because blood backs up into the atria and subsequently into the pulmonary veins, increasing the hydrostatic pressure in those veins. In ARDS, BNP levels, the ejection fraction and myocardial relaxation, and PCWP are all normal. Now, measurement of the PCWP is the most accurate in differentiating ARDS from heart failure, but it's not routinely done because it's invasive. For criteria 4, an arterial blood gas, or ABG, is needed to calculate the PaO2 and the FiO2 ratio. The PaO2 is measured in millimeters of mercury, while the FiO2 is measured as a decimal between 0.21, which is the FiO of the atmospheric air, and 1, which is the maximum FiO2 you can artificially give an individual. In ARDS, the edema of the alveoli prevents adequate ventilation, and some blood ends up in the left atrium without being oxygenated. As a result, giving extra FiO2 doesn't fully correct the hypoxemia, because blood passing by edematous alveoli simply aren't participating in gas exchange. This means that the PaO2 doesn't rise in accordance with FiO2, which decreases the PaO2 to FiO2 ratio. And the more alveoli are affected, the lower the ratio. For example, let's compare a healthy individual with an individual with ARDS. A healthy individual breathing room air, which has an FiO2 of 0.21, would have a PaO2 of 100 millimeters of mercury. So a partial pressure oxygen, or PaO2 of 100, divided by an FiO2 of 0.21 is 476. Now, an individual with ARDS may require an FiO2 of 0.5 to achieve a PaO2 of 100. So that would be 100 divided by 0.5, or 200. And if the individual with ARDS needed a higher FiO2, say 1, then their ratio would be only 100. Therefore, the PaO2 to FiO2 ratio can help determine the severity of ARDS, which corresponds to mortality rates. A ratio between 200 and 300 is considered mild, 100 to 200 is moderate, and less than 100 is severe ARDS. When it comes to the treatment of ARDS, it's crucial to diagnose and treat the underlying cause. For example, giving antibiotics to an individual with sepsis. Now, to address the ARDS directly, the FiO2 is adjusted to try to maintain an oxygen saturation above 88%, and the individual is usually intubated and mechanically ventilated. But see, in ARDS, the alveoli are quite fragile, and so the positive pressure that comes from mechanical ventilation can actually over-distend the alveoli, worsening the ARDS. That's where lung protective ventilation comes into play. This strategy includes giving the individual a low tidal volume, which doesn't over-distend the fragile alveoli, with the maximum tidal volume being 6 milliliters per kilogram. Low tidal volumes contribute to a lower minute ventilation, the total volume ventilated in a minute, and that means that the individual is expelling less carbon dioxide. But that's okay. That's called permissive hypercapnia, meaning that there's some respiratory acidosis that will occur as a part of the trade-off of protecting the alveoli from injury due to high tidal volumes. Additionally, because many of the alveoli are compressed or narrowly collapsed, it's important to use high positive end expiratory pressure, or PEEP. Typically, when a healthy individual breathes out, their alveoli collapse at the end of expiration and then easily pop open again with inspiration. But in ARDS, because there's a lot of fluid and the surfactant is diluted, the alveoli might collapse and then not open again. So we give ARDS individuals a bit of positive pressure right at the end of expiration, so that their alveoli are always open and don't collapse. This also helps reopen some alveoli that have already collapsed, increasing the available surface area for gas exchange. As an added benefit, recruiting more alveoli and preventing them from collapsing also prevents overdistension, because the alveoli share the tidal volume, decreasing the volume that each individual alveoli ends up having. So think peeping is sharing. Now, a few additional things that can be done in ARDS to decrease the pulmonary edema include restricting intravenous fluids or giving diuretics, assuming that this is safe to do. Finally, when you think of mechanical ventilation, you picture an intubated individual lying supine. Well, flip your thinking and that individual. Prone position ventilation has been shown to improve oxygenation and mortality rates in severe ARDS. One theory on why this might work is that the heart and abdominal organs don't compress the lungs as much in the prone position, allowing the lungs more room to expand. Finally, it's worth mentioning that corticosteroids have no role in the treatment of ARDS. Alright, now for a quick recap. ARDS is diffuse lung inflammation and pulmonary edema due to a systemic illness like sepsis. The diagnosis of ARDS requires symptoms developing within 1 week, bilateral diffuse infiltrate on a chest x-ray, symptoms that can't be explained by congestive heart failure, and a ratio of PaO2 to FiO2 that is less than 300. Management includes identifying and treating the underlying cause, oxygenation, and mechanical ventilation. To prevent ventilation-induced lung injury, a combination of low tidal volumes below 6 milliliters per kilogram and high PEEP are provided. Finally, prone position ventilation has shown to improve the outcomes in individuals with severe ARDS.
Pneumonia is due to inflammation of the lung alveoli from an infection. Typically, fluid that's filled with white blood cells starts to fill up the alveoli. And that inflammatory fluid essentially replaces the air that's normally in the alveoli, and that fluid interferes with gas exchange. Pneumonia typically causes a fever, cough, and shortness of breath, along with tachypnea and tachycardia, and occasionally hypoxemia. If the infection is near the pleural surface, it can cause pleuritic chest pain, which is pain that worsens with inspiration. On chest exam, there's dullness on percussion, increased tactile fremitus, which is an increased sensation of vibration when palpating over the affected area and asking the individual to speak, and agophony, which is increased resonance of transmitted sounds and makes the letter E sound like the letter A. On auscultation, bronchial breath sounds or inspiratory crackles might be heard. The diagnosis of pneumonia is based on having clinical signs and symptoms along with abnormal chest imaging, most commonly a chest X-ray. In pneumonia, a chest X-ray typically shows either a lobar consolidation or a diffuse interstitial infiltrate. Pneumonia has to be distinguished from atelectasis, which is when there's collapse of a region of the lung, a complication that often happens in individuals after surgery. On a chest X-ray, atelectasis shows up as a wedge-shaped region with its apex at the hilum, with an ipsilateral shift of structures due to volume loss. In contrast, in a pneumonia, there's usually normal or increased volume with a consolidation that doesn't have an apex at the hilum, and no shift in structures. Now, in addition to imaging, some lab tests suggestive of pneumonia include an elevated white blood cell count and elevated markers of inflammation, like procalcitonin and C-reactive protein. It's thought that these generally increase much more in bacterial pneumonia versus viral pneumonia. For individuals with pneumonia, the next step is to figure out the setting in which the pneumonia developed. If the pneumonia was acquired anywhere in the community, but not in a hospital, it's called community-acquired pneumonia, or CAP. CAP can develop in anyone, but most commonly affects the elderly and individuals with underlying diseases, like chronic obstructive pulmonary disease, or COPD, as well as alcoholism or smoking. If the pneumonia was acquired more than 48 hours after admission to the hospital, it's called hospital-acquired pneumonia, or HAP, or HAP. Finally, a subgroup of HAP called ventilator-associated pneumonia, or VAP, refers to pneumonia that was acquired more than 48 hours after endotracheal intubation. In the majority of cases, antibiotics are selected based on the most likely pathogens in a given situation, and this is called empiric coverage. The initial step in managing CAP is determining whether an individual should be cared for in an outpatient, inpatient, or intensive care unit, or ICU setting. One set of criteria is called CURB 65. The C is for confusion, U is for uremia, defined as a blood urea nitrogen, or BUN, greater than 20 milligrams per deciliter. R is for a respiratory rate greater than 30 breaths per minute. B is for systolic blood pressure below 90 millimeters of mercury, or a diastolic blood pressure below 60 millimeters of mercury. And 65 is for the age of 65 or older. Each positive criterion is given 1 point, and individuals with a score of 0 or 1 are generally treated in an outpatient setting. Those with a score of 2 are treated in an inpatient setting, and those with a score of 3, 4, or 5 are treated in an intensive care unit, or ICU. Sputum and blood cultures are not usually sent in the outpatient setting. However, they're both sent in individuals going to the intensive care unit, and should be sent for certain individuals in the inpatient setting, like those with cavitary infiltrates and those with alcohol intoxication. CURB 65 is popular because it's fairly straightforward and easy to apply. But there are other more elaborate scoring systems like the Pneumonia Severity Index, which takes more into account like vital signs and an individual's comorbidities. So let's say that an individual will be treated as an outpatient. If that individual has no comorbidities and also hasn't been on antibiotics in the past 3 months, then they can get an oral macrolide like azithromycin, or oral doxycycline. However, if the individual has comorbidities like chronic heart, lung, kidney, or liver disease, asplenia, which is functional or anatomical absence of the spleen, immunosuppression, or if they've used antibiotics in the past 3 months, then they're more likely to have an antibiotic-resistant pathogen. So in these situations, the individual should not get started on an antibiotic that they've recently taken. These individuals are treated with either a combination of an oral beta-lactam, like amoxicillin clavulanic acid plus a macrolide, or monotherapy, with an oral fluoroquinolone like levofloxacin or moxifloxacin. However, since ciprofloxacin doesn't reach high enough levels in the lungs to be effective, it's not an option here. If an individual needs to be treated as an inpatient, then one treatment option is with an intravenous beta-lactam, like ceftriaxone, cefotaxime, or ampicillin, along with a macrolide or doxycycline. An alternative treatment approach is monotherapy with an intravenous fluoroquinolone like levofloxacin or moxifloxacin. Finally, if an individual needs to be in the intensive care unit, then they're typically treated with a combination of an IV beta-lactam plus either a macrolide, doxycycline, or fluoroquinolone. If an individual in the ICU might have Pseudomonas aeruginosa, then an anti-pseudomonal beta-lactam should be used, like piperacillin tazobactam, ceftazidime, or cefepime. And if an individual might have methicillin-resistant Staphylococcus aureus, or MRSA for short, then vancomycin or linezolid should be used. Now, although empiric antibiotic coverage is mainly based on the treatment setting, the diagnostic workup and empiric antibiotics can differ a bit based on the organisms that are suspected, based on the appearance of the chest X-ray. One appearance is a lobar pneumonia, which is where a lobe of the lung is involved and often there are air bronchogram. That's where the alveoli are opacified, or white, and the nearby bronchi are filled with air and appear dark, making them easier to see. Overall, the most common cause of a lobar pneumonia is Streptococcus pneumoniae, and when it's suspected, a pneumococcal urine antigen test can be done to confirm the diagnosis. Other pathogens like Haemophilus influenzae and Moraxella catarrhalis are sometimes seen in individuals with chronic obstructive pulmonary disease, or COPD. Another specific cause is Staphylococcus aureus, which typically causes a post-viral pneumonia. That's where an individual with viral pneumonia, like from influenza, will be on the mend, and then will suddenly get sicker. That's because the virus damages the epithelial lining of the lungs, and makes a bacterial superinfection with Staphylococcus aureus or Streptococcus pneumoniae much more likely. One group of individuals that develop recurrent pneumonias are those with cystic fibrosis, because the thick mucus in the airways impairs microbial clearance. Common organisms implicated in cystic fibrosis include Pseudomonas aeruginosa, Staph aureus, and Burkholderia cepacia. Another appearance is a diffuse interstitial pattern on a chest X-ray. Bacteria that cause this appearance are called atypical bacteria, and they include Mycoplasma pneumoniae, Legionella pneumophilia, and Chlamydophilia pneumoniae. They're atypical because they're difficult to grow using standard culture methods, occur in younger adults, and cause milder symptoms. This pattern is thought to develop because the inflammation is localized to the interstitial walls of the alveoli, but not the alveolar space. Mycoplasma pneumoniae classically develops among young, healthy individuals who live in close contact with one another like soldiers in military barracks. Mycoplasma can also cause some unique extrapulmonary findings, like bullous laryngitis, which is a blistering infection of the tympanic membrane, as well as autoimmune hemolytic anemia due to the formation of IgM antibodies that agglutinate when exposed to cold temperature. Legionella tends to happen in individuals exposed to contaminated water sources, like hotel air conditioners or water tanks on cruise ships. Legionella can also cause extrapulmonary symptoms like relative bradycardia and hyponatremia. Relative bradycardia is where the heart rate stays the same even if there's a fever, which is an unusual pattern. Hyponatremia is thought to be due to syndrome of inappropriate antidiuretic hormone, or SIADH, which causes excess water to get reabsorbed by the kidneys. If Legionella is suspected, a Legionella urine antigen test can be done to confirm the diagnosis. Finally, there are some animal exposures that put an individual at risk. For example, exposure to farm animals and their secretions increases the risk of Coxiella burnettii, also called Q fever. Also, exposure to birds like parrots is a risk factor for chlamydia psittaci. Exposure to mouse droppings in urine is associated with hantavirus, which can cause fever, pneumonia, and renal failure. Additionally, fungal pneumonias tend to happen in certain geographic areas. For example, histoplasmosis, which is caused by Histoplasma capsulatum, is found in Ohio and the Mississippi River valleys in the US, and is associated with exposure to soil contaminated with bird and bat droppings. Individuals present with fever, weight loss, night sweats, pneumonia, pancytopenia, hepatosplenomegaly, and generalized lymphadenopathy. Blastomycosis is located in the upper Midwest, like Wisconsin. Individuals often present with pneumonia, skin lesions, osteomyelitis, and genitourinary involvement like prostatitis. In general, mild cases of histoplasmosis and blastomycosis are treated with itraconazole, while disseminated cases are treated with amphotericin B. Also, influenza A and B and many other viruses can cause a viral pneumonia, particularly in the elderly or individuals with chronic lung disease. This results in acute worsening of symptoms and a bilateral diffuse interstitial infiltrate on chest X-ray. This is in contrast to a post-viral bacterial pneumonia, which tends to cause a lobar consolidation or cavitation. Alright, moving on to HAP and VAP, both of which are caused by organisms that are generally more antibiotic resistant, like gram-negative bacteria like Pseudomonas aeruginosa, Klebsiella pneumoniae, and Escherichia coli, as well as gram-positives like methicillin-resistant Staphylococcus aureus or MRSA. In addition, HAP or VAP affects high-risk individuals that are generally older, often have lung disease, and are immunocompromised, and in the case of VAP, have been ill enough to need mechanical ventilation. A sputum culture from the lower respiratory tract is particularly helpful because it's more likely to reveal the pathogen. The culture can be obtained by doing a bronchoalveolar lavage. In a bronchoalveolar lavage, a flexible tube that's attached to a camera is placed down the trachea and fluid is suctioned out of the lungs. Alternatively, an endotracheal tube sample can be obtained if the individual is intubated. Once the sample is obtained, it can be sent off to the lab for culture and gram stain. Individuals with HAP and VAP are inpatients or in the intensive care unit, and should be treated with empiric antibiotics that cover gram-negative rods like Pseudomonas. Therefore, options include a cephalosporin like ceftazidime or cefepime, a carbapenem like imipenem or meropenem, a monobactam like aztreonam, or piperacillin tazobactam. In addition, we need to add another antibiotic that covers MRSA. Therefore, we add either vancomycin or linezolid. Now, if the cultures come back negative, discontinue the antibiotics and think about another cause of their symptoms. If the cultures are positive and the individual is clinically improving, then narrow the antibiotics according to the culture results. Let's say the cultures are positive, however the individual is not getting better. In such a case, you should evaluate for a complication like an abscess or a parapneumonic effusion. Now, one specific type of pneumonia is aspiration pneumonia, and it typically happens among those with an impaired swallowing mechanism, like individuals who are intoxicated with alcohol or individuals with neurological dysfunctions like those with a stroke. These individuals can aspirate foods and liquids as well as their own secretions, bringing oral flora deep into the airways, causing the aspiration pneumonia. Aspiration pneumonia can happen in both a community and hospital setting, so it's usually a cause of CAP or HAP. The infection is often polymicrobial, often including oral anaerobes and gram-negative bacteria, and that can lead to purulent, foul-smelling sputum and formation of a lung abscess. If the individual was upright when the aspiration happened, it most often affects the right lower lobe, and if the individual was in a supine position, then the posterior segment of the right upper lobe is most often affected. Now, whether it's a CAP, HAP, or VAP, pneumonia can result in some complications like parapneumonic pleural effusions and lung abscesses. Sometimes the inflammation from the pneumonia can result in a parapneumonic effusion, which is when there's inflammation of the pleural space that results in a pleural effusion. Oftentimes, the chest X-ray might show a cavitation with an air fluid level. and that suggests that some of the infection has been walled off and has formed into a lung abscess. Unlike most abscesses in the body, lung abscesses can sometimes get treated without drainage and simply with a prolonged course of clindamycin, which covers the anaerobes, and vancomycin, which covers MRSA if it's suspected. When it comes to effusions, a sample of the pleural fluid should be taken by inserting a needle through the chest wall, a procedure called a diagnostic thoracentesis. Now, a parapneumonic effusion is often sterile, meaning a gram stain and culture of the fluid are usually negative. If the effusion is small and the patient is not in respiratory distress, then it typically resolves with antibiotics only. However, if the effusion is large, or the individual is hypoxic or in respiratory distress, then in addition to giving antibiotics, an ultrasound-guided therapeutic thoracentesis should be done to ease symptoms. In contrast to a parapneumonic effusion, an empyema happens when bacteria have invaded into the pleural space. Empyemas are often loculated and full of bacteria, pus, and adhesions. If the pleural fluid sample shows a positive gram stain and culture, has a pH of less than 7.20, or has a glucose level below 60 milligrams per deciliter, then that indicates that it's an empyema. In addition to a more prolonged antibiotic course, empyemas need to be drained using a thoracostomy or chest tube. Video-assisted thoracoscopic surgery, or VATS, which is kind of like a laparoscopy of the chest, can be used to surgically drain more complicated empyemas. Fortunately, there are vaccines that can help prevent pneumonia. There are 2 pneumococcal vaccines, which protect against Pseudomonas pneumoniae. There's 13-valent pneumococcal conjugate vaccine, or PCV13, which covers 13 different types of Streptococcus pneumoniae. And the pneumococcal polysaccharide vaccine, or PPSV23, which covers 23 different types. Any adults 65 years or older should be given the PCV13 vaccine, followed by the PPSV23 vaccine 6 to 12 months later. This sequential vaccination method can also work for high-risk adults less than 65 years, like those who are immunocompromised, have asplenia, sickle cell disease, as well as those with cerebrospinal fluid leak, or have a cochlear implant. In addition, the PPSV23 vaccine should be given alone as a one-time vaccine to adults less than 65 years old, who are current smokers or have chronic medical conditions like diabetes, heart, lung, kidney, or liver disease. Finally, all adults should get the inactivated intramuscular influenza vaccine annually to prevent viral pneumonia from influenza. Now, in addition, some specific ways to prevent aspiration events leading to HAP include keeping the bed elevated at least 30 degrees and limiting usage of nasogastric tubes. And one way to help reduce the risk of VAP is to wean intubated individuals off the ventilator as soon as possible. Alright, as a quick recap. Pneumonia is diagnosed based on symptoms like cough and fever and an abnormal chest x-ray, which might show a lobar consolidation or an interstitial infiltrate. And in some cases, there might be a cavitation or pleural effusion. Pneumonia is classified into community-acquired pneumonia, or CAP, and hospital-acquired or ventilator-associated pneumonia, or HAP and VAP. CAP is defined as a pneumonia in which the organism was acquired anywhere in the community outside the hospital. HAP and VAP are defined as pneumonia starting more than 48 hours after admission to a hospital or endotracheal intubation, respectively. Decision-making tools like the CURB-65 are used to determine whether CAP should be treated inpatient, outpatient, or in the intensive care unit, and the antibiotic choice depends on the setting. Sputum samples for gram stain and culture, as well as blood cultures, should be obtained for individuals with CAP in the intensive care unit, as well as those with HAP or VAP. Complications of pneumonia include parapneumonic effusion, empyema, and lung abscess. Preventative measures to decrease the risk of acquiring pneumonia include providing the pneumococcal and influenza vaccines.
Two people came to your clinic one day. Mariah is a 54-year-old smoker who came in with productive cough with yellow sputum and left-sided chest pain. Physical examination reveals fever, tachycardia, and tachypnea. Her lung sounds are barely audible, but it had crackles at the left base. Next is Jeremy, a 64-year-old man who was hospitalized for a stroke 2 weeks ago. He recently developed a cough and right-sided chest pain. He's tachycardic and has a fever of 38.4 degrees Celsius. Examination reveals fremitus, decreased breath sounds, and dullness to percussion in the right lower lung field. Chest x-rays were performed which showed a left lower lobe infiltrate in Mariah's case, and a right lower lobe infiltrate in Jeremy's. Now, both people have pneumonia. Pneumonia is an infection of the lung tissue. Some microbes can overcome the innate defenses of the lungs and immune system to colonize the bronchioles or alveoli. These pathogens then trigger an inflammatory response. Inflammatory cells such as white blood cells, dead bacteria, proteins, and fluid from the damaged tissue form a fluid called exudate, which can be coughed up and expelled from the body. However, they can also accumulate in the lungs, filling up the alveoli. We can divide pneumonia into classic pneumonia or atypical pneumonia, depending on symptoms. So with classical pneumonia, high-yield symptoms might include dyspnea or shortness of breath, fatigue, and fever. Individuals might also develop pleuritic chest pain, which is characterized by sudden and intense sharp stabbing or burning pain in the chest when inhaling and exhaling, and productive cough with yellow sputum. Besides these, high-yield signs that might come up on your exam include dullness to percussion, which suggests that there's a lung consolidation. This occurs because the air in the alveoli is replaced by pus and fluid, so the sound will lose its normal tympanic or drum-like quality. There's also tactile fremitus, which is when you can feel increased vibrations when you place your hand on the individual's chest or back in the area of the consolidation, and they say 99. Similarly, if you auscultate the area with the consolidation, the 99 will sound louder, and this is called bronchophony. This is because sound waves and vibrations travel better through the fluid-filled consolidated tissue than air-filled healthy tissue. For a similar reason, if you put your stethoscope on the area with the consolidation, you can hear bronchial breath sound, where the sound of the air moving in the bronchi is transmitted clearly through the consolidated area. This is higher pitched and louder than the normal vesicular breath sound, where the sound waves pass through the more air-filled alveoli. Next is egophony, which is increased resonance in the area with consolidation. So when asked to say the letter E, it will sound like the letter A. Late inspiratory crackles can also be heard over the affected area. Crackles are popping lung sounds made when air passes through the fluid in the collapsed alveoli. Finally, people with pneumonia will often have tachypnea and tachycardia. Now, there are many ways to categorize pneumonia. One way would be by the causative microbes. Usually, pneumonia is caused by viruses and bacteria, and rarely fungi as well. In adults, the most common viral cause is influenza. This type usually has an abrupt onset and tends to develop secondary bacterial pneumonia. Next is atypical pneumonia, or the classic bacterial pneumonia, and it's most often caused by either Streptococcus pneumoniae, Haemophilus influenzae, or Staphylococcus aureus. Atypical or walking pneumonia is also caused by bacteria, but the individual won't develop the classic symptoms. In atypical pneumonia with Mycoplasma pneumoniae, a bacteria without a cell wall, individuals usually present with insidious onset, headache, non-productive cough, and sometimes no fever. If you see these symptoms in a question prompt, it's safe to assume that the answer is atypical pneumonia with Mycoplasma pneumoniae. Another clue is that it tends to occur in areas with many people packed together, like in military recruit training camps and prisons. Also common in these populations are chlamydial pneumonia, and it can be caused by either Chlamydophila pneumoniae, Chlamydophila p. psittaci, and Chlamydia trachomatis. Now, another cause of atypical pneumonia is Legionella pneumophila, which causes more severe symptoms like headaches, mild cough, confusion, high fever, and watery diarrhea. This bacteria can be found in water systems or water-based cooling systems in hotels, which is why this infection is also common in travelers. The next high-yield concept is that people in certain age groups are more at risk for certain types of microbial infections. In neonates, or those younger than 4 weeks, the most common cause of pneumonia are group B streptococci and Escherichia coli. In those 4 weeks to 18 years, the condition is typically caused by viruses like the respiratory syncytial virus, but also by bacteria such as Chlamydia trachomatis, which is more common in those younger than 3, and Chlamydophila pneumoniae, which is usually found in school-aged children. Streptococcus pneumoniae is also a common cause of pneumonia in this age group. Next, in those 18 to 40 years, the most common causes are Mycoplasma, Chlamydophila, and Streptococcus pneumoniae, but also viruses like influenza. The last age group is individuals over 40, especially the elderly over 65. The most frequent causes are Streptococcus pneumoniae, anaerobes, and viruses. Okay, besides age, remember that in IV drug users, pneumonia is usually caused by Staphylococcus aureus and Streptococcus pneumoniae. These are also common causes of pneumonia in people with cystic fibrosis. But a very high-yield pathogen associated with cystic fibrosis is Pseudomonas aeruginosa. Another special group is people who are immunocompromised. The more frequent cause includes Staphylococcus aureus, enteric gram-negative rods, and viruses. HIV-positive individuals with a CD4-positive lymphocyte count under 200 cells per microliter can also suffer from AIDS-related opportunistic pathogens, like the fungus Pneumocystis gyrovecii. This type of pneumonia can cause respiratory failure or pneumothorax if left untreated, and was a common cause of death in AIDS patients. Moving on, in those who've acquired pneumonia after a viral infection, the most common culprit is either Streptococcus pneumoniae, Staphylococcus aureus, or Haemophilus influenzae. And finally, in post-organ transplant patients who are on immunosuppressants, pneumonia with intranuclear and cytoplasmic inclusion bodies histologically points to opportunistic infection by cytomegalovirus. Pneumonia can also be categorized by where it's acquired. The most common is community-acquired pneumonia, and it's when a person gets sick outside of a hospital or healthcare setting. It's usually caused by Streptococcus pneumoniae. Okay, so next is hospital-acquired pneumonia, or nosocomial pneumonia, which is when a person gets pneumonia when they are already hospitalized for something else for at least 2 days. It tends to be more serious because these individuals often have a weakened immune system, and the microbes in the hospital are often resistant to common antibiotics. Some high-yield bacteria to remember are methicillin-resistant Staphylococcus aureus, or MRSA, which is usually carried by asymptomatic hospital staff. Legionella pneumophila, which can also be found in water systems or water-based cooling systems in hospitals, is also common. Another category is ventilator-associated pneumonia, which is a subset of hospital-acquired pneumonia. It often develops when ill individuals are intubated for more than 48 hours. Oftentimes, bacteria like Pseudomonas aeruginosa and Staph aureus can form a biofilm on the endotracheal tube. Individuals on a ventilator can't cough, so over time, microbes move directly from the tube into the lungs and cause pneumonia. Now, in addition to inhaling microbes, there are other ways to develop this disease. Aspiration pneumonia happens when you accidentally breathe in food, drinks, or even gastric contents. It's gravity dependent, meaning that the location where pneumonia will develop depends on your position. Remember that if you were to breathe in food while lying on your back, it would most likely involve the posterior segments of the upper lobe and the superior part of the lower ones. If you're standing or sitting upright, the basilar segments would be affected. Now, aspiration pneumonia tends to occur in people with impaired gag and cough reflexes. So a high-yield fact is that most common in individuals who abuse drugs or alcohol, or if they have brain injuries that can cause swallowing issues. Aspirated gastric contents can be particularly nasty because the stomach acid can cause a chemical irritation in addition to the infection. Pulmonary infections in those alcohol use disorders include both anaerobic and aerobic bacteria, especially Klebsiella pneumoniae, which is also a common cause of pneumonia in those with diabetes. This type of infection is often associated with lung necrosis and abscesses. Keep in mind that all of these types of pneumonia can also be characterized by where the infection occurs. In bronchopneumonia, the infection can be patchy throughout the lungs, involving the bronchioles as well as the alveoli. In atypical or interstitial pneumonia, the infection is mainly just outside the alveoli in the interstitium. And in lobar pneumonia, the infection causes complete consolidation of a whole lobe of the lung, meaning that the entire region is filled with fluid. Usually, lobar pneumonia happens in stages, and this can be high yield. The first stage is congestion, which happens between day 1 and 2. This is where the blood vessels and alveoli start filling with excess fluid. The next stage is red hepatization, and it happens between days 3 and 4. This is where exudate, which contains red blood cells, neutrophils, and fibrin, starts filling the air spaces and makes them more solid. The name hepatization refers to the lungs taking on a liver-like appearance due to the buildup of reddish-brown exudate. The third stage is gray hepatization, which happens around days 5 to 7. In this stage, the lungs are still firm, but they turn pale gray because the red blood cells in the exudate are starting to break down. The last stage is called resolution, and this happens around day 8 and continue for up to 3 weeks. In this stage, the exudate gets digested by enzymes, ingested by macrophages, or coughed up. Diagnosis typically begins with a chest X-ray, and a very high-yield fact is that the exudate appears as an infiltrate or opacity in individuals with pneumonia. Also note that X-ray can help locate the infection. Bronchopneumonia typically shows up as patchy areas that are spread out throughout the lung. In lobar pneumonia, exudate is localized to a single lobe or set of lobes. In atypical or interstitial pneumonia, the infiltrate often spreads throughout the lungs, but is often concentrated in the perihilar region that looks reticular or web-like. There can also be more linear opacities around pulmonary vasculature, usually veins, or along the periphery of the lungs along the pleura, and these are called curly B lines, and are a classic sign of pulmonary edema. Then, sputum culture and gram stain are needed to identify the pneumonia-causing bacteria. There are also some lab tests suggestive of pneumonia, like an elevated white blood cell count and elevated markers of inflammation, like procalcitonin and C-reactive protein. Now, the diagnosis for atypical pneumonia can be a bit different. In atypical pneumonia, with Mycoplasma pneumoniae, the X-ray often appears worse than the individual symptoms would suggest. So if you see this in a question, think of Mycoplasma pneumoniae. Diagnosis is then confirmed by serological tests. More specifically, there's a greater than 4-fold increase in IgM titer. Next, remember Mycoplasma pneumoniae requires an acellular medium called Eaton agar, enriched with cholesterol, to grow. Another thing to know is that Mycoplasma pneumoniae leads to what is known as cold autoimmune hemolytic anemia. This condition is characterized by autoantibodies that react to the cold and bind to the erythrocyte membrane, leading to premature erythrocyte destruction. Diagnosis is made by a positive Coombs test, where an antibody against the autoantibody is added to the blood, causing abnormal clumping. Next, diagnosis of Legionella pneumophila infection can be confirmed by Legionella urine antigen tests. Another clue is that there's a high number of neutrophils, but the absence of organisms on sputum gram stains, since the bacteria have a cell wall that inhibits staining. Also keep in mind that it requires a buffered charcoal yeast extract medium supplemented with L-cysteine and iron. Chlamydia infection is usually diagnosed via PCR, nucleic acid amplification, and by Giesma stain, where the bacteria is seen as cytoplasmic inclusions. And finally, Pneumocystis gyrovecii can be seen as disc-shaped bodies on a methenamine silver stain of lung tissue, obtained by either bronchoalveolar lavage or lung biopsy. The treatment of pneumonia depends on the type and severity of pneumonia. Since bacteria are the most likely cause, antibiotics are often prescribed. In addition, cough suppressants and pain medications and supplemental oxygenation are often used to help with symptoms. Now let's go through some of the antibiotics that are most commonly tested. For typical pneumonia, the most commonly used antibiotics are penicillin or cephalosporin in infection with Streptococcus pneumoniae, amoxicillin with or without clavulanate for Haemophilus influenzae, and nafcillin or vancomycin for Staphylococcus aureus. In atypical pneumonia with mycoplasma, Legionella, and chlamydia, the best choice is either macrolides, doxycycline, or fluoroquinolone. In aspiration pneumonia, clindamycin seems to be the best option, as it covers common anaerobes. For pneumocystis pneumonia, trimethoprim sulfamethoxazole is usually used for treatment and dapsone as a prophylaxis for HIV-positive people with a CD4 positive count under 200 cells per microliter. Alright, as a quick recap, pneumonia is an infection of the lungs that results in consolidation or infiltrates where the tissue is filled with exudate. Based on the clinical picture, it can be either typical or atypical. The disease can also be classified by using either community-acquired or hospital-acquired, with some of those being ventilator-associated pneumonias. Aspiration pneumonia is associated with food or gastric content aspiration. Pneumonia can also be characterized by where the infection is in the lungs. Bronchopneumonia is spread throughout the lungs. Atypical or interstitial pneumonia happens in the interstitium around the alveoli, and lobar pneumonia usually infects an entire lobe of the lung. Now, back to our cases. Mariah was admitted with crackles at the left lung base, productive cough with yellow sputum, chest pain, and systemic signs of inflammation like fever, tachycardia, and tachypnea. X-ray revealed a left lower lobe infiltrate, which, given her symptoms and history, are enough to diagnose her with community-acquired pneumonia. In this case, a sputum sample is taken for culture and staining, and she was started on antibiotics. The other individual, Jeremy, who was already hospitalized 2 weeks ago for an acute stroke, developed a cough and right-sided chest pain, tachycardia, and a high fever. Examination revealed fremitus, decreased breath sounds, and dullness to percussion in the right lower lung field. Chest X-ray revealed a right lower lobe infiltrate. Because his rather severe symptoms developed after being hospitalized, we can diagnose Jeremy with hospital-acquired pneumonia. Sputum culture alongside gram stain and culture were done, and he was also started on antibiotics.
Lung cancer is the leading cause of cancer death worldwide in both males and females. It's broadly classified into non-small cell lung cancer, accounting for 85% of all lung cancers, and small cell lung cancer, accounting for the remaining 15%. Small cell lung cancers are centrally located in the lung. Non-small cell lung cancer is further subclassified into 4 subtypes. The most common one is adenocarcinoma, which usually develops at the periphery of the lung. There's also the term bronchoalveolar carcinoma, which refers to adenocarcinoma in situ, which is where the adenocarcinoma tumor isn't quite as aggressive and hasn't yet crossed the basement membrane. The other 3 subtypes of non-small cell cancer include squamous cell carcinoma and carcinoid tumors, which are usually centrally located, as well as the rare large cell carcinoma, which can be located either centrally or peripherally. Now, the most important risk factor for the development of lung cancer is tobacco smoking, which accounts for more than 90% of cases. This usually comes in the form of cigarettes, but also includes cigars, pipes, and hookah, also called shisha. There is a dose-dependent linear relationship between the pack years, the number of cigarette packs per day, times the number of years of smoking, and the risk of lung cancer. Secondhand smoking, which is involuntarily inhaling tobacco smoked by other people, also increases the risk of lung cancer. Additionally, individuals exposed to asbestos for a long period of time, such as those working in shipbuilding or construction industry, are also at increased risk. Although classically associated with mesothelioma, which is a malignancy of the pleura, asbestos more commonly causes adenocarcinoma. Other risk factors include radon exposure, which is found in high concentrations in basements, as well as exposure of chest radiation, such as in treatment of lymphoma. Individuals with lung cancer typically present with symptoms, or are asymptomatic but have a suspicious nodule that's found incidentally on chest imaging. The symptoms of lung cancer can be broadly classified into 5 categories. The first category includes local symptoms, like cough, hemoptysis, and shortness of breath. If the airway is obstructed by a growing tumor, then a person can also develop recurrent infections distal to the obstruction. The second category is constitutional symptoms, which includes fever, unintentional weight loss, and fatigue. These symptoms often indicate more advanced disease. The third category is local invasion, which are symptoms from the tumor damaging surrounding mediastinal structures. For example, a tumor that pushes up against the superior vena cava can cause SVC syndrome, where there's shortness of breath and swelling of the face and arm. Another example is when a tumor pushes up against the phrenic nerve, causing paralysis of the hemodiaphragm, or when it pushes up against the recurrent laryngeal nerve, causing a hoarse voice. Pancoast tumors, which are usually non-small cell lung cancers located peripherally, can push up against the brachial plexus, causing shooting arm pain and weakness. Pancoast tumors can also damage the nearby cervical sympathetic chain, causing Horner's syndrome, which causes ptosis, meiosis, and facial anhidrosis. If the tumor invades into the pleura, then it can result in a pleural effusion, causing shortness of breath, pleuritic chest pain, and dullness on percussion. The fourth category are symptoms due to distant metastasis. Lung cancer typically metastasizes in the brain, causing headaches and vomiting, the bone, which can cause pain or fractures, the liver, which can cause abdominal pain, or the adrenal gland, which is usually asymptomatic, but can cause adrenal insufficiency. The fifth and final category are symptoms due to paraneoplastic syndromes, which can clue you towards a specific subtype of lung cancer. For example, small cell cancers are made of immature neuroendocrine cells, so they ectopically produce hormones, like antidiuretic hormone, which leads to syndrome of inappropriate antidiuretic hormone secretion, or SIADH, which results in hyponatremia, or adrenocorticotropic hormone, which results in Cushing's syndrome. Small cell lung cancers can also cause the production of antibodies against the presynaptic calcium channels of the neuromuscular junction, causing Lambert-Eaton myasthenic syndrome. This results in less acetylcholine release from the presynaptic junction, causing muscle weakness. Usually, the muscle weakness improves as an individual uses the affected muscle group, differentiating it from myasthenia gravis, which has the opposite pattern. Small cell lung cancer can also cause the production of antibodies against Hu antigens, which are found on neurons. If cerebellar neurons are mainly affected, it leads to symptoms like ataxia and nystagmus. If neurons in the cerebrum are affected, then it can lead to symptoms like dementia and seizures. Squamous cell lung cancers sometimes produce parathyroid hormone-related peptide, or PTHrP, which mimics PTH, causing hypercalcemia, and as a result of the negative feedback, it leads to low PTH levels. Adenocarcinoma causes a paraneoplastic syndrome called hypertrophic osteoarthropathy, which leads to fingernail clubbing, joint pain, and proliferation of long bone periosteum in the femur and tibia, causing bone pain. Large cell carcinoma can produce the beta subunit of human chorionic gonadotropin, or beta-HCG, which can cause gynecomastia in males or galactorrhea in females. Finally, carcinoid tumors can secrete serotonin, causing carcinoid syndrome, which can lead to symptoms like flushing, wheezing, dizziness, and diarrhea. The serotonin can also induce fibrosis of the mitral and aortic valves. Often, elevated serotonin levels can be detected by screening the urine for a metabolite of serotonin, 5-hydroxyindole acetic acid, or 5-HIAA. In someone with symptoms of lung cancer, the first step is usually a chest X-ray. If there's evidence of a pleural effusion, then a diagnostic thoracentesis can be done to obtain a sample of the pleural fluid. The fluid may have malignant cells, and if it does, then it means that the lung cancer has invaded into the pleura, which is a hallmark of metastatic cancer, and that it has a poor prognosis. The cells in the pleural fluid also tell you the type of lung cancer. Now, rather than a pleural effusion, the chest X-ray might instead show a parenchymal lesion, like in a nodule, a cavitary mass, or an enlarged hilar lymph node. In that situation, a CT scan with intravenous contrast can be done to better define the tumor location, locate mediastinal or hilar lymph nodes, and look for evidence of local invasion. All of this helps to stage the tumor, and helps to identify a potential target for a tissue sample. For example, if the CT scan shows a centrally located tumor that has invaded the lumen of an airway, then you may insert a bronchoscope into the airway and do a transbronchial biopsy. Alternatively, if the tumor is outside the lumen, then an endoscopic bronchial ultrasound can be used to guide the biopsy needle. If the CT scan shows a peripherally located tumor, then a transthoracic approach makes more sense. You can use a live CT scan or a live X-ray called fluoroscopy to guide your biopsy needle through the chest wall and obtain a tissue sample. Sometimes a more invasive technique, the video-assisted thoracoscopic surgery or VATS, has to be done. This is like a laparoscopy of the thoracic cavity, where a scope is placed into the chest wall to get access to the tumor. Alright, now based on the cells or tissue, it's possible to identify the type of lung cancer. Next, it's important to figure out the degree of spread to see if it can be resected. Treatment options can include surgical resection, chemotherapy, immunotherapy, targeted therapy, radiation therapy, and pain management. The choice depends on the subtype and stage of the lung cancer. For example, metastatic lung cancer cannot be resected, and unfortunately, the majority of small cell lung cancers have already metastasized at diagnosis. Therefore, small cell cancers are often treated with a combination of chemotherapy and radiotherapy. Additionally, prophylactic irradiation of the brain can help prevent metastasis and prolong survival in small cell lung cancer. In contrast, non-small cell lung cancers are often treated with surgical resection of the tumor, plus a small border of healthy tissue around and any involved nearby lymph nodes when it's possible, along with adjuvant radiotherapy or chemotherapy. Now, an alternative scenario in lung cancer is when a solitary pulmonary nodule is incidentally detected on chest imaging. Specifically, there's a lesion that's less than 3 centimeters surrounded by normal lung parenchyma, with no lymphadenopathy. Usually, the individual is asymptomatic, and the differential diagnosis includes infectious causes like tuberculosis and fungal infections, hamartomas, which are benign tumors of the lung, and malignant lung cancer. A key risk factor that suggests a malignant lung cancer is an older individual with a history of smoking. The first step is to compare the pulmonary nodule to previous chest X-rays to see if it's a new growth. A new nodule, or an old lesion that has changed in size in the past 2 years, warrants a CT scan, whereas a nodule that hasn't changed in 2 years can be followed up with annual imaging. Now, if a CT scan is obtained, then some key features offer more clues. Nodules that have a smooth, regular border are less than 8 millimeters and have a dense central calcification that looks like a piece of popcorn are more likely to be benign. Whereas nodules that have an irregular border are over 2 centimeters and have asymmetric calcification are more likely to be malignant. If a nodule looks like it may be malignant, then a biopsy is usually obtained. If a nodule looks benign, then it's usually followed up every 3 months. Often, it's hard to know whether a nodule is more likely benign or malignant based on CT imaging. And in those scenarios, a positron emission tomography combined with a computed tomography, or PET-CT scan of the chest, can be helpful. This is done by giving the individual an intravenous bolus of radiolabeled glucose, called fluorodeoxyglucose. Highly metabolic active cells, like those present in a malignant nodule, take up FDG, and tissues and organs where those cells are located light up on the CT. So, if the PET-CT is positive, then the nodule is often biopsied. In terms of preventing lung cancer, most of it comes down to avoiding smoking, as well as secondhand smoke, by getting family members to quit smoking. In fact, smoking cessation at any time is effective in preventing lung cancer. In terms of screening for lung cancer, individuals who are 50 to 80 years old, have smoked more than 20 pack years, and are currently smoking or quit less than 15 years ago should receive a non-contrast chest CT each year. Alright, as a quick recap. Individuals with lung cancer can either be symptomatic or present with an asymptomatic solitary pulmonary nodule. Symptoms include local symptoms, or those related to parenchymal destruction, like cough and hemoptysis, constitutional symptoms, like fever and weight loss, local invasion, like Horner syndrome, distal metastasis, like brain and adrenal metastases, and paraneoplastic syndromes like SIADH, Cushing syndrome, and Lambert-Eaton myasthenic syndrome. In symptomatic individuals, after a chest X-ray and a CT scan, a biopsy is obtained using the transbronchial, transthoracic, or surgical approaches depending on the tumor location. If a pleural effusion is evident, thoracentesis is done. On the other hand, for solitary pulmonary nodules, the first step is to look at older chest X-rays. The decision to biopsy depends partially on the nodule's characteristics, like its size, border, and calcification. Finally, the treatment of small cell lung cancers is primarily using chemotherapy, while non-small cell cancers are surgically resected, in addition to radiotherapy and chemotherapy.
Lung cancer or bronchogenic carcinoma is defined as a tumor originating in the lung parenchyma or within the bronchi. It typically arises from lung epithelial gene mutations due to long-term exposure to cancer-causing agents, mainly tobacco use, but also exposure to asbestos or radon. Based on histopathological findings, lung cancer is classified into two main groups: small cell lung cancer, or SCLC, and non-small cell lung cancer, or NSCLC, which includes adenocarcinoma, squamous cell carcinoma, large cell carcinoma, and bronchial carcinoid tumor. If a patient presents with a chief concern suggesting lung cancer, first you should perform an ABCDE assessment to determine whether the patient is unstable or stable. If the patient is unstable with severe respiratory distress or hypotension, then you must first stabilize the patient's airway, breathing, and circulation. In severe cases, you may also need to intubate the patient. Next, obtain IV access and, if needed, provide supplemental oxygen. Finally, don't forget to put your patient on continuous vital sign monitoring, including heart rate, blood pressure, and pulse oximetry. All right, now let's go back to the ABCDE assessment and discuss stable patients. First, obtain a focused history and physical examination. Order labs like a CBC and CMP, and finally, order imaging, primarily a chest X-ray and a chest CT scan. Here's a clinical pearl. Yearly lung cancer screenings with CT scan is recommended for patients who are 50 to 80 years of age that currently smoke, or 50 to 80 years of age who have quit smoking within the past 15 years and have at least a 20-pack year smoking history. History typically reveals cough, shortness of breath, pleuritic chest pain, as well as unintentional weight loss and fatigue. If the lung cancer invades surrounding vessels, the patient could report hemoptysis or coughing up blood. Some patients may also have a history of recurrent episodes of pneumonia involving the same spot. Next, check the patient's history for occupational and environmental risk factors. The most important ones include tobacco use and asbestos exposure. Other risk factors that you should know include marijuana, cocaine, vaping with electronic cigarettes, as well as exposure to radon gas and air pollution. But that's not all. Underlying lung conditions such as COPD, pulmonary fibrosis, and tuberculosis can also increase the risk of lung cancer. On the other hand, the physical examination findings in a patient with lung cancer are often nonspecific, but might include tachypnea or distal extremity clubbing. The same goes for lab results, which are also nonspecific, but could reveal anemia, low serum glucose, thrombocytopenia, hypercalcemia, hyponatremia, and hypokalemia. Finally, the chest X-ray and CT scan will show a pulmonary nodule or mass. Now, here's a high-yield fact. Certain findings can give you clues as to the type of lung cancer. For instance, tumors located at the apex of the lung, called Pancoast tumors or superior sulcus tumors, can compress adjacent structures like the brachial plexus, leading to ipsilateral shoulder and arm pain, paresthesia, or even atrophy of the hand muscles, and can also compress sympathetic nerve fibers, leading to Horner syndrome with ipsilateral ptosis, meiosis, and facial anhidrosis. Keep in mind that the majority of Pancoast tumors are adenocarcinomas. Moreover, lung cancers can cause different paraneoplastic syndromes. For instance, squamous cell carcinomas may produce PTH-related peptide, which in turn can lead to hypercalcemia. On the other hand, bronchial carcinoid tumors can release serotonin and cause carcinoid syndrome, which can present with flushing, diarrhea, wheezing, and even right-sided valvular heart disease. Lastly, small cell lung cancer may cause a variety of other paraneoplastic syndromes. Firstly, they can produce ADH, leading to syndrome of inappropriate antidiuretic hormone secretion, or SIADH, which is characterized by euvolemic hyponatremia and decreased serum osmolality, as well as inappropriately elevated urine osmolality with high sodium. Small cell lung cancer can also produce ACTH, which in turn stimulates cortisol production, leading to Cushing syndrome, characterized by moon facies, weight gain with increased abdominal fat and striae, but thin limbs and muscle weakness, as well as osteoporosis, hypertension, and diabetes mellitus. Lastly, small cell lung cancer can trigger the production of antibodies against presynaptic voltage-gated calcium channels in the neuromuscular junction, leading to Lambert-Eaton syndrome, which presents with muscle weakness that gets better with exertion or repetitive nerve stimulation. Okay, at this point, you should suspect that your patient may have lung cancer. Your next step is to order a bronchoscopy with biopsy for centrally located tumors or a CT-guided transthoracic needle aspiration biopsy for peripherally located tumors that cannot be reached with bronchoscopy. In transthoracic needle aspiration biopsy, an ultrasound or CT scan is used to guide the needle to the tumor. Once you set the needle into the tumor, take the biopsy sample and send it to your pathology team. Next, assess the biopsy results. If the biopsy results show histopathologic findings specific for small cell carcinoma or combined small cell carcinoma, diagnose small cell lung cancer. Next, proceed to TNM staging to determine the appropriate treatment plan. If the patient's small cell lung cancer is stage 1, 2, or 3, treat with chemotherapy and radiation therapy and obtain surgical consultation. If the small cell lung cancer is stage 4, meaning that there's distant metastasis or malignant pleural effusion, you can treat the patient with chemotherapy alone. Now, let's go back to the biopsy result. If histopathology reveals findings specific to adenocarcinoma, squamous cell carcinoma, large cell carcinoma, or bronchial carcinoid tumor, you can make a diagnosis of non-small cell lung cancer. Next, proceed to T&M staging to determine the appropriate treatment plan. If the patient's non-small cell lung cancer is stage 1 or 2, obtain a surgical consultation for a video-assisted lobectomy and mediastinal lymph node dissection. Once the cancer is removed, continue the treatment with postoperative chemotherapy. On the other hand, treat stage 3 cancer with a combination of chemotherapy and radiation therapy, and stage 4 with chemotherapy only. Finally, if the histopathologic findings are inconsistent with small cell lung carcinoma and non-small cell lung carcinoma, you should consider alternative diagnoses. All right, as a quick recap, lung cancer or bronchogenic carcinoma is defined as a tumor originating in the lung parenchyma or within the bronchi. Based on histopathological findings, lung cancer is classified into two main groups: small cell lung cancer, or SCLC, and non-small cell lung cancer, or NSCLC, which includes adenocarcinoma, squamous cell carcinoma, large cell carcinoma, and bronchial carcinoid tumor. If you suspect lung cancer based on history, physical exam, labs, and imaging findings, obtain a biopsy sample with bronchoscopy for central tumors or with CT-guided transthoracic needle aspiration for peripheral tumors. Once you get the biopsy results, determine the type of lung cancer and use T&M staging to choose the optimal treatment, which may include chemotherapy, radiation therapy, surgical intervention, or a combination of these options.
While doing your rounds, you see two individuals. First is Elsa, a 66-year-old with a history of smoking 2 packs a day for the past 35 years. She came in with progressive shortness of breath and chronic productive cough, which appeared 2.5 years ago but recently got worse. On examination, she presents with pursed lip breathing, barrel chest, and diminished breath sounds with wheezing. Spirometry was requested, and it showed signs of moderate respiratory obstruction, including an important reduction in forced expiratory volume in 1 second. The other individual is James, a 7-year-old with a history of wheezing and coughing episodes that began 2 years ago. The episodes used to be only during the winter, but in the past 6 months they increased in frequency and severity. His father has a history of asthma, and the child himself has eczema. Physical examination and spirometry was normal. Now, both seem to have some type of obstructive lung disease, but first a bit of physiology. The respiratory tree can be divided into the conducting zone, which consists of large airways like nose, pharynx, larynx, trachea, and bronchi, and the respiratory zone, consisting of respiratory bronchioles, alveolar ducts, and alveoli. Lining the lumen of the airways, you've got the epithelium, mostly composed of one layer of ciliated pseudostratified columnar epithelial cells up until the beginning of terminal bronchioles, where it is replaced by cuboidal cells. The ciliated pseudostratified columnar epithelial cells have hair-like projections called cilia. The cilia are responsible for eliminating larger particles, like dust, that reach the terminal bronchioles by moving them towards the pharynx, where they are coughed out. The epithelium also contains the goblet cell, which makes the mucus within the airway. Going deeper past that layer, you've got the basement membrane and loose connective tissue called the lamina propria, which together with the epithelium makes up the mucosa. Beyond the mucosa, there is smooth muscle followed by more connective tissue, and together these two layers make up the submucosa, which is where the bronchial mucinous glands that secrete the majority of the mucus into the lumen of the bronchi live. Finally, in the bronchi, but not the bronchioles, there is a layer of cartilage below the submucosa, which stiffens the bronchus and helps to keep it open. Okay, so obstructive lung diseases are a group of conditions characterized by obstruction of airflow, which traps air inside the lungs. Now, because the airway is narrowed down or severely obstructed, exhaled air comes out more slowly than normal, and at the end of a full exhalation, an abnormally large amount of air still remains in the lungs. This is an obstructive respiratory deficit, and it's marked by several changes which can be seen on pulmonary function tests, or PFTs, like spirometry and plethysmography. Spirometry is when you breathe into a tube attached to a machine called a spirometer, which measures the amount of air you breathe in and out and how quick you do it. Plethysmography is when you are placed inside a sealed chamber and asked to breathe through a mouthpiece, which measures the pressure generated by your breathing to calculate the amount of air inside your lungs. Okay, so in obstructive lung diseases, first there's an increase in residual volume, or RV, which is the amount of air left in the lungs after exhaling as much as you can, and in functional residual capacity, or FRC, which is the amount of air remaining in the lungs at the end of a normal exhalation. Second, there's a small reduction in forced vital capacity, or FVC, which measures the amount of air a person can breathe out forcefully after taking as deep a breath as possible, and a significant reduction in forced expiratory volume in 1 second, or FEV1, which measures the total amount of air that can be forcibly exhaled in the first second of the FVC test. This is because these individuals have a narrow airway, which hinders how fast air can leave the lungs. Third, there's a decrease in the ratio of FEV1 to FVC, secondary to the disproportionate decrease in FVC and FEV1. The ratio measures the amount of air a person can forcefully exhale in 1 second relative to the total amount of air they can exhale. Okay, so this decrease in the ratio of FEV1 to FVC is considered the hallmark of obstructive lung disease and can also be used to figure out the severity of the obstruction. Fourth, the total lung capacity is either normal or increased, unlike restrictive lung diseases, where it almost always is decreased. The reason why TLC may increase is that in some obstructive lung diseases, like emphysema, there's air trapping and lungs hyperinflate. TLC is calculated by adding the volume of air left in the lungs after exhalation, or the residual volume, with the FVC. Fifth, there might also be a VQ mismatch, where the V stands for ventilation, which is the air you breathe in, and the Q stands for perfusion, which is blood flow. A VQ mismatch happens because the blood flow is normal, but the lungs don't receive enough oxygen due to airway obstruction, and this is measured by a test called a pulmonary ventilation perfusion scan. Over time, this can lead to hypoxemia because there's not enough oxygen in the blood. In order to keep the VQ ratio constant as the ventilation decreases, the pulmonary vessels start to constrict in order to reduce perfusion to the areas that do not participate in gas exchange. This is called hypoxic vasoconstriction, and it leads to pulmonary hypertension. Over time, pulmonary hypertension puts a strain on the right heart and can lead to right heart failure, or cor pulmonale, which manifests as jugular venous distension, peripheral edema, and hepatomegaly due to congestion. Finally, it's important to assess the gas exchange, which varies depending on the particular disease. This is done by measuring the diffusing capacity of the lungs for carbon monoxide, also known as DLCO. This test involves asking the individual to inhale a small amount of carbon monoxide and seeing how well it diffuses. Another high-yield concept is how obstructive lung disease can change the flow-volume loop, which is used to show airflow on the y-axis as it relates to lung volume on the x-axis. So imagine taking the deepest breath you can and then exhaling it out as forcefully as possible. The volume you're going to exhale is the forced vital capacity, and what will be left after the maximal expiration will be the residual volume. And these two combined give us the total lung capacity. Now, since in most cases of obstructive lung disease, the residual volume is increased while the total vital capacity is normal or increased, the loop will typically show a shift to the left. Okay, now let's look at each specific disease, starting with chronic obstructive pulmonary disease, or COPD. The condition is characterized by obstruction of airflow due to either chronic bronchitis or emphysema. Sometimes patients can have one or the other. However, most patients have elements of both chronic bronchitis and emphysema at the same time. In addition, the triggers of the inflammation of the airway are often the same and include environmental triggers, like inhalation of toxic substances such as tobacco smoke, or occupational pollutants like dust and silica. Now, chronic bronchitis is an inflammation of the tracheobronchial tree that leads to increased mucus production. So what happens is that a trigger, usually smoking, irritates the mucosa of the airways, leading to hypertrophy and hyperplasia of mucinous glands in the main bronchi and goblet cells in the bronchioles. One test that's used post-mortem is the Reed index, which measures the ratio of the thickness of the bronchial mucinous glands layer relative to the total thickness of the wall between the epithelium and the glands. Normally the ratio should be less than 0.3, but for people with chronic bronchitis, it can be over 0.4. Now, hyperplasia and hypertrophy of the mucinous glands increases mucus production in both the main bronchi and the bronchioles, which causes airway obstruction. Usually, signs and symptoms of chronic bronchitis include productive cough due to excess mucus secretion and wheezing from the narrowing of the airways. Crackles and rales can be heard on auscultation of the lungs, which are caused by the popping open of small airways. There's also hypoxemia and hypercapnia, both secondary to the mucus plugs blocking air exchange. Additionally, the obstruction of the airflow can get so bad that deoxygenated blood from the right side of the heart reaches the left side without any participation in gas exchange in the pulmonary capillaries. This is called a shunt, and it's the reason why some people develop cyanosis, which is a blue discoloration of the skin. So, a high-yield fact is that these individuals are sometimes referred to as blue bloaters. And finally, when there's a mucus plug obstructing the airways, there's a high risk for pneumonia behind the obstruction. Classic symptoms of pneumonia include high fever, chills, confusion or irritability, worsening dyspnea, and changes in sputum color, thickness, or amount. The other COPD is emphysema, which is the permanent enlargement and loss of elasticity of the alveolar wall secondary to alveolar injury. This is caused by irritants like tobacco smoke that triggers inflammation in the alveoli. The way this happens is that neutrophils gather and release destructive proteases like elastase, which breaks down the elastin in alveolar walls, making them weaker, so the alveoli collapse during exhalation. Alveoli also lose their ability to stretch and recoil, so they can't return to their normal shape. The result is alveoli trap a tiny bit of air distal to the point of collapse. Now, alveoli are organized in clusters called acini, and depending on which part of the acini are affected, we can have one of three types of emphysema. The most common one is centriacinar or centrilobular emphysema, and it only damages the central or proximal alveoli of the acinus. This is the pattern seen with cigarette smoking, and it typically affects the upper lobes of the lungs. There is also panacinar emphysema, where the entire acinus, usually in the lower lobes, is uniformly affected, and this is often associated with alpha-1 antitrypsin deficiency. Since the alveolar neutrophils are always releasing proteases to help clear the debris, the body protects itself by releasing alpha-1 antitrypsin, which is a protease inhibitor that prevents excessive collateral damage. Now, those with alpha-1 antitrypsin deficiency have no way to stop the proteases, so they end up with damaged air sacs earlier in life, especially if they smoke, since it will attract more neutrophils to the area. And finally, we have paraseptal emphysema, in which the distal alveoli of the acinus are most affected, and this type typically affects the lung tissue on the periphery of the lobules near the interlobular septa that separate each lobule. When it comes to signs and symptoms, people with emphysema typically experience shortness of breath. To counteract this, patients might exhale slowly through pursed lips which increases the pressure inside the alveoli to prevent them from collapsing. A high-yield term to describe these individuals is pink puffers, since in the earlier stages of the disease, the alveoli are still able to participate in gas exchange and they don't look cyanotic. Additionally, due to the air trapping and hyperinflation of the lungs, individuals can also develop a barrel-shaped chest. Over time, though, as more and more alveoli are damaged, emphysema can lead to hypoxemia. Now, COPD diagnosis is based on history, clinical findings, and a series of tests. To start with, pulmonary function tests can help detect any changes in lung volumes associated with obstructive lung disease. Next, if COPD seems likely, an inhaled bronchodilator, like albuterol, is given to the person and pulmonary function tests are measured again to see if the obstruction is reversible. Reversibility is defined as more than 12% increase in FEV1 after administering the bronchodilator. Okay, so note that unlike asthma, COPD is an irreversible disease, so giving a bronchodilator should not change the values too much. This means that if FEV1 doesn't increase by more than 12% after the bronchodilator, then COPD is the likely diagnosis. Next, it's important to find out if the individual has predominantly chronic bronchitis, emphysema, or both. Typically, the diagnosis of chronic bronchitis is clinical and based on a productive cough that lasts for at least 3 months and over a period of 2 or more years. Another clue for you is a complete blood count showing polycythemia, which is an increase in the red blood cell number. Individuals with chronic bronchitis develop secondary polycythemia as a response to chronic hypoxemia, which triggers increased production of erythropoietin by the kidneys. By contrast, emphysema can't be diagnosed clinically as it is defined by structural changes in the lungs. This means an X-ray or CT scan is needed, which might show enlargement of the air spaces, increased anterior-posterior diameter, a flattened diaphragm, and increased lung field lucency. Additionally, a DLCO might also show a decrease in the lung's diffusing capacity secondary to alveolar wall destruction, unlike those with chronic bronchitis. And finally, alpha-1 antitrypsin deficiency screening is done in those who develop COPD without having any risk factors. Treatment of COPD largely involves reducing risk factors, like stopping smoking, but also managing associated illnesses. Because infections often trigger COPD exacerbations, people should be given the influenza vaccine annually. If an infectious exacerbation does happen, these individuals may need a course of antibiotics, corticosteroids, inhaled short-acting bronchodilators, including beta agonists like albuterol and muscarinic agents like ipratropium, as well as supplemental oxygen. Be careful, though, as giving too much oxygen could potentially be harmful in patients with COPD. In healthy individuals, the stimulus of respiratory drive is normally the partial pressure of carbon dioxide, or PaCO2, which stimulates the central chemoreceptors in the medulla. In those with long-standing hypoxemia, this role is assumed by the partial pressure of oxygen, or PO2, which stimulates the peripheral chemoreceptors in the carotid and aortic bodies. So if you give too much oxygen to someone with COPD, their only respiratory stimulus disappears, which leads to respiratory failure. Long-term treatment of COPD includes long-acting agents if short-acting agents cannot relieve symptoms. Other options include long-acting beta agonists like formoterol and long-acting muscarinic agents like tiotropium or umeclidinium. Now, in some individuals with severe hypoxia or there's cor pulmonale, home supplemental oxygen might also be needed. Okay, next is asthma, an episodic disorder caused by inflammation and hyperresponsiveness of the bronchial smooth muscle, leading to reversible bronchoconstriction. Although the specific causes of asthma are ultimately unknown, it's thought to be due to a combination of genetic and environmental factors like air pollution, cigarette smoke, and car exhaust, as well as allergens. Some worth remembering include dust, animal dander, cockroaches, and mold. For your exam, don't forget that aspirin has also been known to trigger symptoms in some individuals with asthma. Aspirin-induced asthma has to do with leukotriene B4 overproduction, which is a compound that results in bronchospasm and increased mucus production. What's especially high yield is that aspirin-induced asthma is often combined with nasal polyps and chronic sinusitis. Okay, so regardless of the trigger's nature, it causes a type 1 hypersensitivity reaction. It starts when the trigger causes an excessive activation from type 2 helper T cells, or Th2 cells, and causes them to produce cytokines, like IL-4. These cytokines cause B lymphocytes to produce IgE antibodies against the foreign antigens. These then coat mast cells and cause them to release granules containing histamines, leukotrienes, and prostaglandins. These inflammatory mediators cause bronchoconstriction and edema, which leads to airway obstruction. Another cytokine released by Th2 cells is IL-5, which activates eosinophils, and these cells release more inflammatory mediators which contribute to the symptoms. Initially, these inflammatory changes are reversible, but over time, irreversible changes take place, like scarring and fibrosis in the basement membrane of the airwaves, causing permanent reduction of airway diameter. Furthermore, there's smooth muscle hypertrophy and hyperplasia that worsens the obstruction. The signs and symptoms of asthma come and go and tend to be more frequent in winter or when exposed to an irritant such as cigarette smoke. An asthma episode can include coughing and a feeling of chest tightness due to airway irritation, but also tachypnea, dyspnea, and wheezing due to airway edema. Okay, the first step of diagnosis is asking for a personal or a family history of asthma, atopic eczema, and allergy. Next, it's important to conduct pulmonary function tests. Now, because asthma is an episodic obstructive lung disease, these tests show the typical signs of obstructive pulmonary disease only when the individual is having symptoms. If asthma seems likely, an inhaled bronchodilator is given to the person, just as in COPD. Note that unlike COPD, giving a bronchodilator should reverse the pulmonary function test measurements back towards normal, confirming the diagnosis. Now, if they do not have symptoms at the time, we can try to induce asthma by performing the methylcholine challenge test. Methylcholine binds to muscarinic receptors on bronchial smooth muscle, causing mild bronchoconstriction. In a healthy individual who doesn't have asthma, this bronchoconstriction is negligible, and there's no significant change in pulmonary function test measurements. But because an asthmatic's bronchial smooth muscle is hyperresponsive, methylcholine causes a 20% decrease in their FEV1 from the baseline. Now, it's important to remember that the methylcholine challenge test is highly sensitive, meaning that a negative test can rule out the diagnosis, but nonspecific, so a positive test doesn't confirm the diagnosis. Another thing to be aware of is that DLCO is usually normal or slightly increased in asthma. The rationale behind this is that in asthma there is no destruction of the alveolar membrane. Instead, air gets trapped in the alveoli, causing them to stretch out and increasing the surface area available for gas exchange. Occasionally, sputum analysis can also be done, which often shows the so-called Kirschmann spirals. These are shed, elongated epithelial cells that can form whorled mucus plugs. The plugs can be particularly dangerous because they not only block the exchange of air, but they also block inhaled medications from getting to the site of inflammation. Another thing you might see in the sputum that will help you think of asthma are Charcot-Leyden crystals, which look like hexagonal, double-pointed crystals formed by the breakdown of eosinophils secondary to IL-5 stimulation. Other findings might include a decreased inspiration-expiration ratio. In normal spontaneous breathing, the expiratory time is about twice as long as the inspiratory time, which gives an inspiration-expiration ratio of 1 to 2. In those with asthma, because the airway obstruction leads to prolonged expiration, the ratio can be 1 to 4 or sometimes even 1 to 5. Those with severe asthma might also develop something called pulsus paradoxus, which is a drop in the systolic blood pressure of more than 10 milligrams mercury during inspiration. Pulsus paradoxus results from a decrease in cardiac stroke volume with inspiration due to greatly increased left ventricle afterload. This is caused by the dramatic increase in negative intrapleural and transmural pressure in someone struggling to breathe against significant airway obstruction. Finally, chest X-ray, which might show signs of hyperinflation like a flattened diaphragm, blood eosinophil count, and serum IgE level, which might be increased. A skin reactivity test of various allergens can also be done. But the fact is that they are less sensitive, meaning that normal findings on these tests cannot exclude the diagnosis. While there's no cure for asthma, there are treatments to help manage the symptoms and prevent an asthma attack. In acute exacerbations, a short-acting bronchodilator like albuterol is often administered through an emergency inhaler. It causes the smooth muscles to relax and dilates the airways, but as side effects, albuterol can cause tremor and arrhythmias. Next, keep in mind that in those with chronic asthma, corticosteroids like fluticasone or budesonide, which inhibit the synthesis of cytokines, are considered first-line therapy. Additionally, a long-acting beta agonist or a muscarinic antagonist bronchodilator can be added to control symptoms if corticosteroids are not enough. If this fails, theophylline, a methylxanthine which likely causes bronchodilation by inhibiting phosphodiesterase, can be added to the treatment plan. However, this drug has limited use due to its cardiotoxicity and neurotoxicity. Alternatively, anti-leukotrienes like montelukast and zafarlukast, which block leukotriene receptors, or xyleutin, a 5-lipoxygenase pathway inhibitor that blocks the conversion of arachidonic acid to leukotrienes, can be given in addition to corticotherapy, especially in those with aspirin-induced and exercise-induced asthma. Now, there are many other ways to prevent an asthma episode. In general, people with asthma should avoid or minimize contact with triggering substances. Next, long-acting bronchodilators like salmeterol and formoterol can also be used for prophylaxis. Rarely, chromones like cromolyn, which work by preventing mast cell degranulation, can also be used to prevent acute asthma symptoms. And finally, bronchiectasis is characterized by damaged and dilated bronchi and bronchioles secondary to chronic inflammation and mucus obstruction. There are many causes of chronic inflammation, like primary ciliary dyskinesia, where the cilia don't move normally, and that leaves mucus stuck in the airways. Bacteria that are trapped in the mucus start to multiply and can cause pneumonia. If that happens repeatedly, it results in chronic inflammation. Now, if primary ciliary dyskinesia is combined with situs inversus, or reversal of the internal organs, chronic sinusitis, and bronchiectasis, it is called by a fancy name, the Karthagener syndrome. Another example is cystic fibrosis, when the mucus itself is extra sticky, hard to sweep, and therefore it accumulates, causing obstruction and dilation of the bronchi and bronchioles, and thus bronchiectasis. Another cause you might find in a test is allergic bronchopulmonary aspergillosis, which is caused by a fungus called aspergillus that triggers chronic inflammation and damage of the airways, which can progress to bronchiectasis. And then there is airway obstruction, usually caused by tumors, foreign objects, or anything else that can block the bronchus or bronchiole, which subsequently leads to pneumonia and chronic inflammation. Whatever the cause of the inflammation, immune cells in the bronchi and bronchioles release cytokines that damage the ciliated epithelial cells and destroy the elastin fibers in the walls of the airway. As a result, the airways become dilated and become clogged with mucus. Over time, chronic inflammation leads to scarring and fibrosis, which narrows the airways, resulting in airflow obstruction. And as the ventilation decreases, it leads to hypoxic vasoconstriction, meaning that the pulmonary vessels start to constrict in order to reduce perfusion to the areas that do not participate in gas exchange and keep the VQ ratio constant. If that's widespread, it can lead to pulmonary hypertension and, in time, cor pulmonale. Bronchiectasis causes symptoms like wheezing, shortness of breath, and a productive cough with foul-smelling, purulent sputum. If the lungs are severely injured, people might also cough up blood, which is called hemoptysis. Long-term hypoxia can lead to digital clubbing, or rounding of the nail beds, and individuals might also present with symptoms of pneumonia and a history of recurrent infections. A diagnosis of bronchiectasis can be made by CT scan showing dilated bronchi and bronchioles in conjunction with pulmonary function testing detecting signs of obstructive lung disease. Additionally, other tests like genetic testing or a sweat test can be done to look for underlying conditions like primary ciliary dyskinesia and cystic fibrosis. Treatment is usually aimed at treating the recurrent pneumonias with antibiotics and removing excess mucus with percussion or postural drainage. Additionally, individuals need to stay hydrated, which helps prevent airway mucus from becoming thick and sticky. If there's a physical obstruction like a tumor or foreign body, then surgery may be needed to remove them. All right, as a quick recap, Obstructive lung diseases are characterized by blockages or obstructions of the airways, which results in an increase in RV, FRC, and TLC, a reduction of FVC, FEV1, FEV1 to FVC ratio, TLC, and a VQ mismatch, and a normal or decreased DLCO and a left shift in the flow volume loop. Okay, so COPD presents as either chronic bronchitis, emphysema, or both, and it's usually caused by exposure to chemicals and irritants like cigarette smoke. In chronic bronchitis, the trigger stimulates increased mucus production in the airways, which causes a chronic productive cough and wheezing. People with this disorder are often described as blue bloaters. In emphysema, exposure to irritants causes elastin destruction in the small airways, which leads to air trapping. However, people with this disorder don't have hypoxemia early on, which is why they are called pink puffers. Asthma is an episodic disorder characterized by chronic inflammation, which leads to smooth muscle spasms, edema, and mucus production, resulting in coughing and wheezing that's reversible. And finally, in bronchiectasis, the bronchi and bronchioles are chronically inflamed, causing damage to the cilia and the walls of the airways, which leads to their dilation. Over time, excessive fibrosis and mucus cause airflow obstruction. Symptoms include productive coughing, wheezing, and shortness of breath. Now, back to our cases. Elsa has a long history of smoking, and she came in with progressive shortness of breath and chronic productive cough, which first appeared more than 2 years ago. On examination, she presents pursed lip breathing, a barrel chest, diminished breath sounds, and wheezing. Spirometry showed signs of airway obstruction, and given her history of productive cough for more than 2 years and characteristic presentation, a diagnosis of COPD due to chronic bronchitis can be made. Next, James has a 2-year history of eczema and of episodes consisting of wheeze and cough, which have increased in frequency and severity. He also has a family history of asthma. All of this points to asthma. Spirometry was normal, which is why a methacholine challenge test was done. This induced an asthma attack along with a 20% decrease in FEV1 from the baseline, which was reversed by giving bronchodilators, confirming the diagnosis of asthma.
Cystic fibrosis, or CF, is an autosomal recessive disorder in which there's a mutated cystic fibrosis transmembrane conductance regulator, or CFTR protein. The mutated CFTR protein causes secretions to be abnormally thick and sticky, and they build up in the lungs, pancreas, and other organ systems. The CFTR protein is a channel protein that pumps chloride ions into various secretions. Those chloride ions help draw water into the secretions, which helps to thin out the secretion. The most common mutation that leads to cystic fibrosis is the delta F508 mutation. This mutation causes the CFTR protein to not make it to the cell membrane. Without CFTR protein on the epithelial surface, chloride ions aren't pumped into the secretions, and that leaves the secretions thick and sticky. In some countries, diagnosis of cystic fibrosis is done with newborn screening. Usually it's done by detection of a pancreatic enzyme called immunoreactive trypsinogen, or IRT, which is released into the fetal blood when there's pancreatic damage from CF. A confirmatory test is the quantitative pilocarpine iontophoresis, better known as the sweat test, which detects high levels of chloride in the sweat. The reason for this is that in the lungs and pancreas, a mutated CFTR means that chloride can't go out. But in the sweat glands, a mutated CFTR means that chloride can't come in or be reabsorbed. So if chloride levels in the sweat are high, meaning over 60 millimoles per liter, CF diagnosis is very likely. While intermediate levels from 30 to 59 millimoles per liter in infants below 6 months, or 40 to 59 millimoles per liter in older infants, children, and adults, means CF diagnosis is possible. In both cases, DNA testing is done to detect the most common cystic fibrosis-related mutations. If 2 or more of these mutations are detected, 1 in each chromosome, then the diagnosis of CF is confirmed. Having said that, even if only one DNA mutation or no mutation at all is detected, an individual might still have cystic fibrosis, due to some rare mutation that standard genetic testing can't detect. Likewise, normal sweat chloride levels cannot definitively exclude CF. So if CF is still suspected, then the sweat test can be repeated and an expanded DNA analysis can be done to look for even more possible mutations. Another test is the nasal potential difference test, which measures the voltage across the nasal epithelium, which is a reflection of CFTR function. On repeat testing, if the sweat chloride is higher than 60 millimoles per liter, or if two cystic fibrosis-related mutations are detected, or if the nasal potential difference test is abnormal, then the diagnosis is confirmed. But if none of these are found, then cystic fibrosis is very unlikely. Alright, now cystic fibrosis causes different symptoms in different age groups. In a newborn baby, thick secretions can affect the baby's meconium, or first stool. The meconium can get so thick and sticky that it might get stuck in the baby's intestines and not come out, causing small bowel obstruction. This is called the meconium ileus, and it's when a baby doesn't pass meconium within the first day of life. Sometimes the bowel obstruction can cause bilious vomiting and abdominal distension. A rectal examination reveals an empty rectum with no meconium, but with a normal anal sphincter tone. That's unlike Hirschsprung's disease, which also results in a failure to pass meconium, but has abnormally increased sphincter tone. Now, meconium ileus is a surgical emergency because it can lead to bowel perforation and peritonitis. That can lead to septic shock, which can ultimately cause organ failure and death. If a baby is septic, the vital signs show temperature instability, either a fever or hypothermia, as well as tachycardia, tachypnea, and hypotension. And there's typically a distended and rigid abdomen, and a baby that looks mottled and lethargic. In a meconium ileus, abdominal x-rays show dilated bowel loops and air fluid levels proximal to the obstruction, along with a soap bubble, or a ground glass appearance at the site of the obstruction, due to small air bubbles mixed in with the meconium. There can also be linear or curved calcifications, which are a sign of calcified intraperitoneal meconium, in the case of meconium peritonitis. If the diagnosis is still unclear, then a water-soluble contrast enema can be done, and it would typically show a small caliber colon or microcolon, along with little masses of meconium plugging the terminal ileum. Treatment of a meconium ileus requires decompression of the gastrointestinal tract through the nasogastric tube, while giving IV fluids. After that, if there's no perforation and peritonitis, then a hypertonic contrast enema can be given to break up the meconium. If that doesn't work, or if there's perforation and peritonitis, then surgery is needed. Now, in early childhood, the most prominent effect of CF is pancreatic insufficiency. This happens because thick secretions jam up the pancreatic ducts, preventing digestive enzymes from making it into the small intestine. Without those pancreatic enzymes, fat isn't absorbed, causing steatorrhea, or fat-containing stools. Over time, this can lead to poor weight gain and failure to thrive. The backed-up digestive enzymes can also degrade the cells lining the pancreatic ducts and cause an acute pancreatitis, or if there are repeated episodes, a chronic pancreatitis. A diagnosis of pancreatic insufficiency can be made when the levels of elastase, a pancreatic enzyme, in the stool are below 200 micrograms per gram. If the levels are that low, then children are given extra calories in their diet, supplementation with fat-soluble vitamins, which are A, D, E, and K, and pancreatic enzyme replacement therapy, or PERT, which contains enzymes like lipase, amylase, and protease. In addition, the destruction of pancreatic tissue can also reduce the endocrine function of the pancreas, causing insulin-dependent diabetes mellitus. That's why screening starts at age 10 and is repeated annually with an oral glucose tolerance test. This is where a person is given 75 grams of glucose, and 2 hours later, if the blood glucose is 139 milligrams per deciliter or lower, it's normal. If it's 140 to 199, it's pre-diabetes, and if it's 200 or above, it's diabetes. For abnormal results, additional testing with the fasting glucose test is done. That's where the person doesn't eat or drink anything except water for 8 hours. After that, a blood glucose level of 99 milligrams per deciliter or lower is normal. 100 to 125 indicates prediabetes, and 126 or higher indicates diabetes. In addition, there's the HbA1c, which is the proportion of glycated hemoglobin in the blood. HbA1c levels of 5.6% and below are normal. 5.7% to 6.4% indicates prediabetes, and 6.5% or higher indicates diabetes. In terms of treatment, cystic fibrosis-related diabetes can be managed with subcutaneous insulin injections. Usually a long-acting insulin, like detamir or glargine, is introduced first, starting at 0.1 units per kilogram right before bedtime. Doses are then adjusted to keep fasting blood glucose between 70 and 90 milligrams per deciliter. Usually, as children grow, they start to develop thick mucus secretions in their lungs, which become colonized with bacteria. Chronic bacterial infection and inflammation can lead to bronchiectasis, which is damage to the airway walls that causes permanent dilation of the bronchi that fill up with mucus. This causes a recurrent cough with lots of sputum, and if the inflammation erodes into a blood vessel, there could be hemoptysis. Pulmonary function tests, or PFTs, show an obstructive pattern, meaning a decrease in the forced expiratory volume in 1 second, or FEV1, and the ratio of FEV1 to forced vital capacity, FEV1 to FVC. Chest x-rays are initially normal or show mild hyperinflation, with flattening of the diaphragm and increased retrosternal space. But over time, as bronchiectasis develops, it can show up on a chest x-ray as tram track lines radiating from the hyla and ring shadows which represent clusters of cysts, typically in the upper lobes. Clearing out the mucus helps with breathing, and it can be done with chest physiotherapy as well as medications. Medications include bronchodilators, like beta-2 adrenergic agonists, anticholinergic drugs, and theophylline, which helps keep the airways open, and mucolytics, like nebulized N-acetylcysteine, which cleaves disulfide bonds in the mucus glycoproteins, or Dornase alpha, which is a nuclease that cuts up nucleic acids in the mucus to thin it out. Sometimes anti-inflammatory agents, like ibuprofen, and oral or inhaled glucocorticoids, are used to suppress excessive inflammation. Long-term use of the antibiotic azithromycin is also sometimes used to diminish airway inflammation. In addition, some individuals with chronic hypoxemia are given supplemental oxygen. Finally, there are medications called CFTR modulators, like ivacaftor, tezacaftor, and lumacaftor, which work on specific CFTR mutation types and act by boosting production, intracellular processing, or function of the mutated CFTR protein. For example, lumacaftor is a chaperone that can bring the mutated delta F508 CFTR to the cell membrane, and ivacaftor helps CFTR work better when it gets there. So CFTR genotyping can identify which individuals can benefit from specific medications like this, an example of personalized medicine. Now, if the bacterial load of a pathogen increases, then that can cause a pneumonia or a CF exacerbation. In neonates and children, pathogens are often gram-positive bacteria, like Staphylococcus aureus or methicillin-resistant Staphylococcus aureus, or MRSA. Whereas in teens and adults, it's usually gram-negative bacteria, like Pseudomonas aeruginosa. A CF exacerbation causes new or increased symptoms, like a productive cough with sputum, dyspnea with exertion, fatigue, decreased appetite, or fevers. If pulmonary function tests are done, there's usually a 10 to 15% decrease in FEV1. On a chest x-ray, because CF causes long-standing changes, CF exacerbations typically look the same or slightly worse from baseline. Sputum cultures are usually sent to identify the pathogens that are responsible, and antibiotics are chosen based on the antibiotic susceptibility of those pathogens. For milder exacerbations, an oral regimen like doxycycline or trimethoprim sulfamethoxazole can be used to treat MRSA. and ciprofloxacin or levofloxacin can be used for gram-negative bacteria. For serious exacerbations, IV antibiotics can be used, like vancomycin or linezolid for MRSA, and piperacillin tazobactam, ceftazidime, and meropenem, along with tobramycin, amikacin, or ciprofloxacin to help treat gram-negative bacteria. Usually this regimen is continued until the individual gets back to their baseline in terms of symptoms and lung function, which is usually a minimum of 10 days to as long as 3 weeks or more. Over time, repeated cystic fibrosis exacerbations can lead to irreversible respiratory failure and death. And a final step is often a lung transplantation, which comes with its own set of risks and challenges related to the surgery, organ rejection, and a lifetime of immunosuppression. In adulthood, another cystic fibrosis-related issue is infertility in men, because they commonly lack the vas deferens, which are the tubes that transport the sperm from the testes to the urethra in the penis. But since sperm production in the testicles is usually normal, these men can usually still have biological children through assisted reproductive technology. Men and women can also have digital clubbing, which describes how the fingernails start to spoon around the fingertips, as well as nasal polyps, which are tissue growths in the nose, and allergic bronchopulmonary aspergillosis, or ABPA, which is a hypersensitivity reaction to the fungus Aspergillus fumigatus that can live in a sinus or lung cavity. ABPA is difficult to spot in someone with cystic fibrosis, and that's why serum total IgE concentrations need to be checked annually. Serum IgE levels lower than 200 international units per milliliter are considered normal, while 200 to 500 international units per milliliter is indeterminate and requires a repeat measurement. Now, if IgE levels are greater than 500 international units per milliliter, it's considered abnormal, and we proceed to an Aspergillus skin test, or a serum immunoassay for IgE to Aspergillus fumigatus. If this is positive as well, we can look for an elevated serum Aspergillus IgG by immunoassay, chest X-ray for pulmonary opacities consistent with ABPA, and a total eosinophil count greater than 500 cells per microliter. A diagnosis of ABPA requires at least 2 of these 3 features. Treatment of ABPA consists of corticosteroids, like oral prednisone, to reduce lung inflammation, as well as antifungal medicines, like itraconazole, to kill the aspergillus. Alright, as a quick recap. Cystic fibrosis is an autosomal recessive disorder involving the CFTR gene, which causes issues with the lungs and pancreas, as well as other organs and tissues. Respiratory features include bronchiectasis, recurrent pneumonia, nasal polyps, and ABPA. Gastrointestinal features include meconium ileus and peritonitis, failure to thrive, and pancreatic disease, both exocrine insufficiency and cystic fibrosis-related diabetes mellitus. Other features include male infertility and digital clubbing. The diagnosis can be based on a newborn screening test, abnormal sweat chloride test with a level above 60 millimoles per liter, having 2 cystic fibrosis-related mutations, or an abnormal nasal potential difference. Chronic treatment includes chest physiotherapy, bronchodilators, mucolytics, and in some cases anti-inflammatory agents, azithromycin, supplemental oxygen, or CFTR modulators. Acute exacerbations usually show new or worsened symptoms and a 10 to 15% decrease in FEV1. And they're treated with antibiotics that target the main pathogen found in a sputum culture. A newborn was delivered 2 days ago at home without any complications. Today he's brought in for examination. The baby has a fever and a distended abdomen that's rigid on palpation. The mother mentions her son started vomiting a green fluid and that he has yet to pass his first stool. She also says he didn't have access to prenatal care throughout the pregnancy. An X-ray was performed, and it showed air fluid levels in dilated bowel loops, along with a soap bubble appearance. A pilocarpine-induced sweat test was done which showed a chloride ion level over 60. Now, the newborn seems to have cystic fibrosis. But first, a little physiology. Normally, elements like ions and water come in and out of the cell through specific channels located on the cell's membrane. A very high-yield fact that you need to know is that there's a particular channel called cystic fibrosis transmembrane conductance regulator, or the CFTR protein, which is an ATP-gated channel, meaning it works by using ATP for energy. It transports negatively charged chloride ions. In cells that produce mucus, it secretes the ion out of the cell, and in cells of the sweat glands, it reabsorbs chloride ions back into the cell. Now, normally cells and mucous membranes pump out chloride ions into the thick mucus, which helps attract water molecules and make it less viscous. This mucus will protect the linings of organs and tissues like the airways, digestive system, and reproductive system. For example, the mucus produced by the glands in the airways allows the tiny cilia to sweep back and forth. This sweeping motion helps move the mucus and the bacteria or foreign particles trapped in it out of the airways. Additionally, the CFTR protein also regulates the function of other channels, like those that transport positively charged sodium ions. Now, cystic fibrosis, or CF, is an autosomal recessive disorder where there's a mutation in the CFTR gene, and it's considered to be the most common lethal genetic disease in the Caucasian population. Keep in mind that the defective gene is located on chromosome 7, and that the defect itself is usually represented by delta F508, an abbreviation that indicates that there's a deletion of 3 nucleotides that code for the phenylalanine at amino acid position 508. Another thing to know is that the delta F508 mutation results in impaired post-translational processing. This means that the protein will be misfolded, and it will not be glycosylated. So it'll be retained in the endoplasmic reticulum, where it's degraded instead of being released to the cell membrane. Without the CFTR protein on the epithelial surface, cells cannot transport chloride ions. In the mucus-secreting cells, the defect prevents chloride from being secreted, which causes intracellular levels to increase. It also leads to a compensatory sodium reabsorption via the epithelial sodium channels, or ENAC, because the inhibitory effect of the CFTR protein on ENAC is missing. Interestingly, this increase in sodium reabsorption causes a negative transepithelial potential difference, which basically means the epithelial surfaces with mucus-producing glands have a significantly more negative electrical charge. This is important because the negative transepithelial potential difference can be measured intranasally, and thus it can be used as a diagnosis test for CF. Okay, so going back to chloride ions. A high-yield concept is that because they're trapped inside the cell, water won't be attracted to the mucus to thin it out. As a result, the mucus secreted by these cells will be abnormally thick, so it builds up and obstructs the organs where it's secreted, causing extensive damage. In parallel, in sweat-producing cells, the defect prevents chloride ions from being reabsorbed, thus it accumulates in the sweat. Now, this leads to a wide range of signs and symptoms, which mostly depend on the individual's age. In a newborn baby, the thick secretions can affect the baby's meconium, or first stool. The meconium can get so thick and sticky that it gets stuck in the baby's intestines, and can cause small bowel obstruction. This is called a meconium ileus, and it's considered a surgical emergency because the obstruction can lead to bowel perforation and peritonitis. On examination, babies initially present a distended and rigid abdomen, and they might look mottled and lethargic. Another sign of obstruction is bilious vomiting, which is when the vomit has a green color due to the high bile content. If bowel perforation happens, it can lead to septic shock, which can ultimately cause organ failure and death. If a baby is septic, the vital signs might show temperature instability, either a fever or hypothermia, tachycardia, tachypnea, and hypotension. Something to keep in mind is if a newborn survives meconium ileus, without proper management, they'll most likely die of cardiorespiratory complications, like pneumonia or bronchiectasis, which accounts for more than 80% of deaths due to CF. In early childhood, the most prominent and high-yield complication of CF is pancreatic insufficiency. This happens because thick secretions block the pancreatic ducts, preventing digestive enzymes from making it into the small intestine. Without those pancreatic enzymes, fat isn't absorbed, causing steatorrhea, or an abnormal amount of fat in a person's stools. Over time, this can lead to poor weight gain and failure to thrive, because most of the nutrients in fat-soluble vitamins like vitamin A, D, E, and K are lost through the stool. Something that you might encounter on your test is avitaminosis A, which is important since it leads to squamous metaplasia of the epithelial lining of pancreatic exocrine ducts. This is particularly problematic because there's already pancreatic damage, usually from the backed up digestive enzymes that'll start digesting the pancreas, causing pancreatitis. Sometimes the destruction of pancreatic tissue can also reduce the endocrine function of the pancreas, causing insulin-dependent diabetes mellitus. As the child grows, their lungs can also be affected, usually because the mucus in their airways are so thick that the cilia can't move them out. So they get repeatedly colonized by bacteria, which causes chronic bacterial infection and inflammation. Sometimes the mucus can get compacted and it starts acting as a mucus plug, which alongside chronic bacterial infection and inflammation leads to bronchiectasis. Bronchiectasis represents damage to the airway walls that causes permanent dilation of the bronchi. This causes respiratory symptoms like cough with lots of sputum, and if the damage extends to the blood vessels, it can lead to hemoptysis. Individuals can also develop recurrent pneumonia, especially when there's chronic lower respiratory infections. There are a couple high-yield bacteria you need to remember. In infants and children, the pneumonia-causing pathogens are often gram-positive bacteria, like Staphylococcus aureus, or methicillin-resistant Staphylococcus aureus. Whereas in teens and adults, it's usually gram-negative bacteria, like Pseudomonas aeruginosa. The recurrence of Pseudomonas aeruginosa pneumonia in CF has been linked, in part, to the bacteria's ability to form biofilms. Biofilms are defined as communities of microorganisms that are attached to a surface, and in Pseudomonas cases, this is possible due to its mucoid polysaccharide capsule, which makes it sticky. Another thing to look out for is allergic bronchopulmonary aspergillosis, or ABPA, which is a hypersensitivity reaction to the fungus Aspergillus fumigatus that can live in the sinus or lung cavity. Sometimes pulmonary symptoms can increase rapidly, causing a CF exacerbation. This usually includes worsening productive cough with sputum, dyspnea with exertion, fatigue, decreased appetite, and fever. Over time, repeated CF exacerbations can lead to irreversible respiratory failure and death. Sometimes the liver and the bile can be affected too. It's thought that the abnormal CFTR protein in the biliary system leads to impaired secretion and deposition of thick, viscous bile and reduced alkalinity. The abnormal bile increases the activity of free radicals, and its stagnation increases the liver's susceptibility to infectious and toxic agents, which end up damaging the hepatocyte directly. In addition, the thick biliary secretion can also obstruct the small bile ducts, damaging the liver and biliary tract even more. In time, hepatic stellate cells, the main culprits of hepatic fibrosis, are activated and start to produce collagen, as well as stimulating the epithelium of bile ducts to release cytokines, which accelerates the fibrotic process. This process, over a number of years, leads to the development of biliary cirrhosis. Other frequently tested complications associated with CF are hypokalemia and contraction alkalosis, which is alkalosis associated with hypovolemia, caused by water and sodium losses via sweating, and with concomitant renal potassium and hydrogen losses. Clinically, these individuals develop symptoms suggestive of hypovolemia, like dehydration, hypotension, tachycardia, and even cardiovascular collapse. In adulthood, a common cystic fibrosis-related issue is the bilateral absence of vas deferens in biological males. Because the sperm transportation is impaired, they're infertile, but not sterile, since spermatogenesis is typically unaffected. In biological females, cystic fibrosis could cause subfertility, meaning these women are fertile, but cannot get pregnant because of the abnormally thick cervical mucus that makes it harder for sperm to successfully penetrate the cervix. Poor nutrition secondary to malabsorption can also lead to irregular ovulation and amenorrhea. Although the fertility issues might be the only signs of cystic fibrosis in adults, individuals can also develop digital clubbing, which describes how the fingernails begin to spoon around the fingertips, and nasal polyps, which are mucosal epithelial growths in the nose. Alright, for diagnosis. Screening can be done at birth via a heel prick test that detects a pancreatic enzyme called immunoreactive trypsinogen, or IRT, which is released into the fetal blood when there's pancreatic damage from CF. The confirmatory test you might come across is the quantitative pilocarpine iontophoresis, better known as the pilocarpine-induced sweat test, which checks for high levels of chloride in the sweat. So if chloride levels are over 60 millimoles per liter, CF diagnosis is very likely, while intermediate levels from 30 to 59 millimoles per liter in infants below 6 months, or 40 to 59 millimoles per liter in older infants, children, and adults, means CF diagnosis is possible. DNA testing can also be done in all age groups to detect the most common cystic fibrosis-related mutations. If 2 or more mutations are detected, 1 in each chromosome, then the diagnosis of CF is confirmed. Another test that might help you diagnose CF, especially in cases where the sweat test was negative, is the nasal potential difference test, which is used to detect the negative voltage across the nasal epithelium associated with CF. Now, CF is rarely diagnosed by itself, which means further testing is necessary to diagnose any of the complications associated with the disease. For example, meconium ileus is diagnosed by a combination of clinical and X-ray findings. Typical abdominal X-ray signs include dilated bowel loops and air fluid levels proximal to the obstruction, along with a soap bubble or ground glass appearance at the site of the obstruction due to small air bubbles mixed in with the meconium. Another complication is bronchiectasis, which is diagnosed by pulmonary function tests, or PFTs, showing an obstructive pattern, meaning a decrease in the forced expiratory volume in 1 second, or FEV1, and the ratio of FEV1 to forced vital capacity. Chest X-ray is also needed, and it might show tram track lines radiating from the hyla, and ring shadows which represent clusters of cysts, typically in the upper lobes. And finally, a CF exacerbation can be diagnosed if there are new or increased symptoms. If pulmonary function tests are done, there's usually a 10 to 15% decrease in FEV1. On a chest X-ray, CF exacerbations typically present as bilateral lower lobe infiltrates. Sputum cultures are usually sent to identify the pathogens that are responsible. Finally, a blood test can show hypokalemia and contraction alkalosis in those with symptoms suggestive of hypovolemia. Treatment is multifactorial. Clearing out the mucus helps with breathing, and it can be done with chest physiotherapy as well as medications. Medications include bronchodilators, like beta-2 adrenergic agonists like albuterol, anticholinergic drugs, and theophylline, which help keep the airways open. Also remember that it can include mucolytics, like nebulized N-acetylcysteine, which cleaves disulfide bonds in the mucus glycoproteins, or dornase alpha, which is a nuclease that cuts up nucleic acids in the mucus to thin it out. Sometimes anti-inflammatory agents like ibuprofen and oral or inhaled glucocorticoids are used to suppress excessive inflammation. Long-term use of the antibiotic azithromycin is also sometimes used to diminish airway inflammation and slow disease progression and prevent CF exacerbations. In addition, some individuals with chronic hypoxemia are given supplemental oxygen. Finally, there are medications called CFTR modulators, like ivacaftor, tezacaftor, and lumacaftor, which work on specific CFTR mutations and act by boosting production, intracellular processing, or function of the mutated CFTR protein. For example, the best choice can be a combination of lumacaftor, which is a chaperone that can correct the misfolded protein and bring it to the cell membrane, and ivacaftor, which opens the chloride channels and improves the ion's transport. Alright, as a quick recap. Cystic fibrosis is an autosomal recessive disorder involving the CFTR gene. The misfolded protein it encodes causes chloride transport impairment in the mucus in sweat-producing cells, resulting in an abnormally thick mucus. This causes obstruction-related issues with the lungs and pancreas, as well as other organs and tissues. CF complications vary from one age group to another, but they can include digestive issues like meconium ileus and liver disease, respiratory complications like bronchiectasis, recurrent pneumonia, and nasal polyps, peritonitis, failure to thrive, and pancreatic disease. Other features include male infertility and female subfertility. In a newborn, it can be screened for with a positive immunoreactive trypsinogen test. It can be confirmed by either an abnormal sweat chloride test, DNA testing, or an abnormal nasal potential difference test. Chronic treatment includes chest physiotherapy, bronchodilators, mucolytics, and in some cases anti-inflammatory agents, azithromycin, supplemental oxygen, or CFTR modulators. Now back to our case. The newborn showed signs of bowel obstruction, which are fever, a distended and rigid abdomen, and bilious vomiting. His history also revealed that he hadn't had his first stool yet, which was supposed to happen within the first day after delivery. This suggests meconium ileus, so an X-ray was ordered, which confirmed the diagnosis based on the dilated bowel loops and air fluid levels proximal to the obstruction, along with a soap bubble or ground glass appearance at the site of obstruction. The newborn's clinical picture is highly suggestive of cystic fibrosis, and a sweat test showing highly elevated chloride ions confirmed the diagnosis. Aware that cystic fibrosis, or CF, is a genetic disorder that affects the lungs. But that's only part of the story. In fact, the name cystic fibrosis refers to the disease's effects on the pancreas, where it can lead to cysts, which are fluid-filled sacs wrapped in a membrane, and fibrosis, excess deposition of connective tissue that can replace or infiltrate normal tissue in an organ. CF is an autosomal recessive disorder involving the CFTR gene, which stands for Cystic Fibrosis Transmembrane Conductance Regulator. And this gene codes for the CFTR protein. CF develops when there's a mutation in the CFTR gene, but because it's autosomal recessive, you need to inherit two mutated CFTR genes, one from mom and one from dad. Now, if mom and dad both have one copy of the mutated gene and one normal gene, they're considered carriers and they don't have the disease. And inheriting CF is much more common in people of European descent. Now, the CFTR protein is a channel protein that pumps chloride ions into various secretions. Those chloride ions help draw water into the secretions, which ends up thinning them out. The most common mutation with CFTR is the delta F508 mutation. Delta means a deletion, and the F, which can also be written as Phe, is short for phenylalanine, and the 508 is the 508th amino acid in the CFTR protein. So the delta F508 mutation is where the 508th amino acid out of 1,480, phenylalanine, is deleted and missing. This CFTR protein with the delta F508 mutation gets misfolded and can't migrate from the endoplasmic reticulum to the cell membrane, meaning there's a lack of CFTR protein on the epithelial surface. And this means that it can't pump chloride ions out, which means water doesn't get drawn in and the secretions are left overly thick. In a newborn, thick secretions can affect the baby's meconium, or first stool, which can get so thick and sticky that it might get stuck in the baby's intestines and not come out. And this is called a meconium ileus and is a surgical emergency. In early childhood, pancreatic insufficiency is the most prominent effect of CF. And this happens because thick secretions jam up the pancreatic ducts, not allowing digestive enzymes to make it to the small intestine. Without those pancreatic enzymes, protein and fat aren't absorbed. And over time, this can lead to poor weight gain and failure to thrive. Fat malabsorption can lead to steatorrhea, or fat-containing stools. Eventually, the pancreas gets damaged because backed up digestive enzymes degrade the cells that line the pancreatic ducts, causing local inflammation. And this can lead to acute pancreatitis, and with repeated episodes, chronic pancreatitis, with the development of cysts and fibrosis like we talked about, giving the disease its name. Finally, the destruction of pancreatic tissue can also compromise the endocrine function of the pancreas, causing insulin-dependent diabetes. It's usually not until later in childhood that lung problems start to crop up. Normally, the cilia, these hair-like projections lining the airways, do a pretty good job of keeping them clean by moving mucus, which catches things like debris and bacteria, toward the pharynx, called mucociliary action. With thick mucus, though, it gets a lot harder to clear, and the mucociliary action becomes defective, which means bacteria is allowed to chronically colonize the lungs. If the bacterial load suddenly increases, it causes symptoms like a cough and a fever, a decrease in lung function, and sometimes changes on a chest x-ray. And this is called CF exacerbation, and usually prompts a round of antibiotics. Pneumonia is one example of a CF exacerbation which requires antibiotic treatment. Examples of problematic bacteria include Staphylococcus aureus, which is gram-positive, and Pseudomonas aeruginosa, which is gram-negative, both of which can be hard to treat if they're resistant to typical antibiotics. In addition, the bacteria usually form a biofilm, where individual bacterial cells are fixed in a matrix of slime, which protects them from the immune system as well as antibiotics. Chronic bacterial infection and inflammation can lead to bronchiectasis, which is airway wall damage causing permanent dilation of the bronchi. Occasionally, if the inflammation erodes into a blood vessel, there can even be hemoptysis, or coughing up of blood. Over time, the repeated CF exacerbations can ultimately lead to respiratory failure, the leading cause of death with CF. Other CF-related issues include infertility in men who commonly lack the vas deferens, which are the tubes that transfer the sperm from the testes to the urethra in the penis. Men and women can also have digital clubbing, where the fingernails begin to spoon around the fingertips, nasal polyps, which are tissue growths in the nose, and allergic bronchopulmonary aspergillosis, or ABPA, which is a hypersensitivity reaction to the fungus Aspergillus fumigatus, which can live in a sinus or a lung cavity. For diagnosis, it's possible to screen for CF in newborns, something that's done in some countries where CF is common, and that helps treatment get started earlier. The newborn screen detects a pancreatic enzyme called IRT, or immunoreactive trypsinogen, which is released into the fetal blood when there's pancreatic damage from CF. And then if a sweat test detects high levels of chloride in the sweat, CF is confirmed. Unlike in the lungs and the pancreas, where chloride can't get out, when CFTR is not working in the sweat glands, chloride can't come in or be reabsorbed, so there's actually high chloride in the sweat. In fact, parents of children with CF sometimes notice that when they're kissing their baby, the baby tastes salty. In terms of treatment, a major goal is around nutrition and healthy weight gain. Fortunately, fat-soluble vitamins A, D, E, and K, extra calories, and replacement of pancreatic enzymes can all be supplemented to help boost nutrition and help the patient absorb nutrients. In terms of pulmonary treatment, there's chest physiotherapy, which loosens the mucus by literally banging on the chest, as well as inhalers. There are also medications like N-acetylcysteine, which cleaves disulfide bonds in the mucus glycoproteins, and Dornase alpha, which is a nuclease that cuts up nucleic acids in the mucus to thin it out. CF lung disease is obstructive, like asthma and COPD, so pulmonary function tests are regularly used to monitor the disease. Finally, because of chronic infections and loss of pulmonary function over time, a lung transplant is sometimes needed. A new hope for patients with CF has been the development of personalized treatments that target specific CFTR mutation types. For example, lumacaftor is a chaperone that can bring the mutated delta F 508 CFTR to the cell membrane, and this is given in combination with ivacaftor. Ivacaftor was originally designed against G551D mutations, but also improves function of mutated delta F 508 CFTR. Even though this isn't a cure, these drugs are a good example of the potential of personalized medicine. In addition to this, though, there are new genetic technologies on the horizon, aimed at actually correcting specific gene mutations. Alright, time for a quick recap. Cystic fibrosis is an autosomal recessive disorder involving the CFTR gene, which most notably causes issues with the lungs and the pancreas, but can also affect other organs.
While on your rounds, you see two individuals. First is Alicia, a 28-year-old African-American individual who comes in with progressive shortness of breath and cough. She also mentions that she lost weight in the past 6 months and that she had tuberculosis a few years ago. Examination reveals painful red skin lesions on each side of her nose and the anterior surface of both legs, along the tibia. The rest of the examination was normal. Next you see a 65-year-old male named Richard, who presents with gradually progressive dyspnea on exertion and dry cough. He has no history of underlying lung disease or other relevant symptoms. On examination, there is nail clubbing, but no other signs that could suggest a particular etiology, like pneumonia or COPD. Pulmonary function tests were performed in both cases, showing signs of a restricted pattern, including a significant reduction in forced vital capacity. Both seem to have some type of restrictive lung disease. But first, a bit of physiology. The lung is compliant, meaning that it can expand and contract because its connective tissue is made up of proteins like elastin and collagen. Compliance is defined as the volume change produced by a change in the distending pressure, and it is expressed as the ratio of delta V, the change in volume, to delta P, which is the change in pressure. In other words, the higher the compliance, the easier it is for the lungs to expand. In contrast, the lung's tendency to collapse and push the air back out is called elastic recoil, which is balanced by the outward pull of the chest wall. Now remember that breathing also involves the structures around the lungs, like the ribs, intercostal muscles, diaphragm, or pleura. During inhalation, the diaphragm and intercostal muscles contract to pull the ribs up and out and expand the chest cavity. This creates a vacuum that pulls the lungs open to allow air in, which eventually reaches the alveoli and specifically a thin membrane called the respiratory membrane, where gas exchange occurs. Air is then expelled by exhalation when the diaphragm and intercostal muscles relax to allow the chest wall to fall and return the chest cavity to normal. Okay, so restrictive lung diseases are a group of conditions in which inhalation fills the lungs far less than normal. There are two types of restrictive lung diseases: diffuse parenchymal lung diseases and extrapulmonary lung diseases. In diffuse parenchymal lung diseases, or DPLDs, previously called interstitial lung diseases, the lung tissue itself is damaged. The result is a fibrotic, rigid lung with reduced compliance and increased recoil that won't easily allow air to enter during inhalation, thereby reducing lung volumes. On your test, if you see graphs or questions mentioning dramatically decreased compliance, you should think of DPLDs, since a reduced delta V over delta P ratio is the hallmark of pulmonary fibrosis. In the extrapulmonary type, something else besides the lungs interferes with the breathing mechanics and prevents chest expansion and lung filling. For example, in scoliosis, because the spine is bent sideways, it can push on the lung on the affected side, impairing lung expansion and filling. Generally, these abnormalities result in a few characteristic changes in pulmonary function tests, or PFTs, like spirometry and plethysmography. Spirometry is when you breathe into a tube attached to a machine called a spirometer, which measures the amount of air you breathe in and out and how quick you do it. Plethysmography is when you are placed inside a sealed chamber and asked to breathe through a mouthpiece, which measures the pressure generated by your breathing to calculate the amount of air inside your lungs. Okay, so in restrictive lung diseases, first there's a decrease in forced vital capacity, or FVC, which is the air exhaled forcefully after taking a deep breath. Second, residual volume, or RV, decreases as well, and it is the air left in the lungs after exhaling as hard as possible. RV, and any lung capacity that includes RV, cannot be measured by spirometry, because it can't be breathed out, even if the person tries to. And this is why plethysmography is necessary. Third, there is also a reduction in total lung capacity, or TLC, calculated by adding FVC to RV. Now fourth, there's also a decrease in functional residual capacity, or FRC, which is the volume of air that remains in the lungs after normal expiration. FRC can also be calculated by adding RV to expiratory reserve, or the air that can still be breathed out after normal expiration. Fifth, there is a decrease in forced expiratory volume in 1 second, or FEV1, which is the air exhaled with maximum effort in the first second. And finally, the FEV1 over FVC ratio, which is normally between 0.7 and 0.8, usually stays about the same, because both volumes decrease proportionally. One particularity you might come across is that the ratio can increase if FVC is reduced more than FEV1. This can happen in some DPLDs, where there's increased elastic recoil, allowing air to be pushed out faster during the first second of expiration. Now, besides the typical PFT changes, most DPLDs are also marked by a decrease in the lung's diffusing capacity for carbon monoxide, or DLCO, which is a measure of how well gases are transferred between the lungs and the blood. The decrease occurs because in DPLDs, there is a thickened fibrotic respiratory membrane, so gases have a hard time passing through it. Another high-yield fact to know is that because less oxygen makes it into the bloodstream, the result is an elevated arterial alveolar or AA gradient, which is the difference between the partial pressure of oxygen in the alveoli, written as P big A O2, and the arterial partial pressure of oxygen, written as P little a O2. In time, because the lung is damaged and filling impaired, some areas of the lung will receive less oxygen than others. But at the same time, blood flow will stay the same throughout the lungs. This is called a ventilation-perfusion mismatch, and it can lead to hypoxemia, mostly because there's less oxygen available for blood to pick up. Hypoxemia is also made worse by an intrapulmonary shunt, which is when the pulmonary arterioles start to constrict to adapt to hypoxemia, effectively shuttling or diverting blood away from the areas that don't receive any oxygen to the ones that do. But if the damage is widespread, then it can lead to vasoconstriction of pulmonary arterioles, which causes pulmonary hypertension. That makes it hard for the right ventricle to pump out blood, causing the right ventricle to hypertrophy, a process called cor pulmonale. Another high-yield concept is how restrictive lung disease can change the flow-volume loop, which is used to show airflow on the y-axis as it relates to lung volume on the x-axis. So imagine taking the deepest breath you can and then exhaling it out as forcefully as possible. In other words, the volume you're going to exhale is the forced vital capacity, and what will be left after maximal expiration inside the lung will be the residual volume. And these two combined give us the total lung capacity. Now, since in most cases of restrictive lung disease, the residual volume and total lung capacity are decreased, the loop will typically show a shift to the right. Now, another thing to keep in mind is that in healthy people, airflow is slower at low lung volumes because elastic recoil decreases proportionately with lung volumes. Low volumes are also associated with high airway resistance because the deflated lungs exert little radial traction on the conducting airways. Radial traction is the force exerted by the lung parenchyma to keep the airways open. By contrast, it's important to understand that those with restrictive pulmonary diseases have low lung volumes, but airflow is actually higher than normal, mostly because both elastic recoil and radial traction are increased, usually due to the fibrotic pulmonary interstitium full of collagen. Let's now talk about the main causes of restrictive lung diseases. Diffuse parenchymal lung diseases, or DPLDs, are conditions that affect the interstitium, the alveoli, the respiratory membrane, as well as the blood vessels and pleura. DPLDs can be broadly classified into two categories. First, there are those with a known cause, which can be subclassified into granulomatous diseases like sarcoidosis and hypersensitivity pneumonitis, occupational exposures, also called pneumoconiosis, like asbestosis, silicosis, berylliosis, and coal workers' pneumoconiosis, and miscellaneous diseases like rheumatoid arthritis, granulomatosis with polyangiitis, Goodpasture syndrome, pulmonary Langerhans cell histiocytosis, and drug toxicity. And second, there are those with an unknown cause, mostly represented by idiopathic pulmonary fibrosis. To start with, granulomatous lung diseases, besides sarcoidosis and hypersensitivity pneumonitis, also include contact dermatitis and the reactions resulting from the tuberculin and candida extract skin tests. Now, these are usually a result of a type 4 hypersensitivity reaction, which is also called a delayed type hypersensitivity because it takes 2 to 3 days to develop. This is a cell-mediated immune response triggered by antigens. The antigen causes a chain reaction that is frequently tested. So first, the antigen gets picked up by an antigen-presenting cell, or APC, like a dendritic cell or an alveolar macrophage. The APC then presents the antigen to a CD4-positive T helper cell, or Th cell, and at the same time starts to secrete interleukin-12, or IL-12, which binds to the IL-12 receptor of a CD4-positive Th cell, causing it to differentiate into a T helper type 1 cell. This stimulates T helper type 1 cells to start secreting IL-2, which helps both it and other T cells in the area proliferate, as well as secrete interferon gamma, which activates phagocytes like macrophages. The activated macrophages, now called epithelioid macrophages, because they have lots of pink cytoplasm similar to squamous epithelial cells, are attracted to the site of antigen exposure. Here, they surround the antigen, forming the center of a ball-like nodule called a granuloma, which is meant to wall off the antigen and prevent it from spreading. On the periphery of the granuloma, there are CD4-positive Th cells and multinucleated giant cells, which are formed when several activated macrophages fuse together. The giant cells are also called Langerhans giant cells and have multiple nuclei which are arranged peripherally in the shape of a horseshoe. Another particularity of the Langerhans giant cells is that they contain cytoplasmic inclusions called Schumann bodies, which are made of calcium and protein deposits. There are also asteroid bodies that look like tiny stars, which are likely pieces of cytoskeleton or lipids. Keep in mind that these Langerhans cells are especially common in sarcoidosis. Now, there are two types of granulomas: caseating, which are associated with central necrosis and seen in infectious etiologies like tuberculosis, and non-caseating, which have no central necrosis and are seen with autoimmune diseases like sarcoidosis, hypersensitivity pneumonitis, or Crohn's disease. Okay, so finally, if the antigen is removed, then the lungs heal up quickly. However, if exposure or the antigen persists, fibroblasts are attracted to the site of injury where they start the process of scarring by depositing fibrin, resulting in a fibrotic lung that is stiff and less compliant, which as a consequence limits lung expansion and volumes. Now that we've looked at the general pathology, let's look at the first disease, sarcoidosis. The precise trigger of this condition isn't known, but there are some associated risk factors that are frequently tested. Genetic risk factors include being of African descent and having a family member with sarcoidosis, and younger females are more commonly affected. Environmental risk factors include a prior infection with Mycobacterium tuberculosis and Borrelia burgdorferi. However, in sarcoidosis, These pathogens are long gone when the autoimmune damage sets in. Basically, dendritic cells, a type of APC, go haywire without the presence of a specific pathogen that the body is trying to destroy, attracting T cells and macrophages to a particular spot of healthy tissue, where they form granulomas. And because it is a systemic disease, sarcoidosis can involve nearly every organ, even if it usually involves hilar lymph nodes, which are located near the point where the bronchi meets the lungs. Sarcoidosis is usually asymptomatic, or it can cause unspecific signs and symptoms like fever, weight loss, fatigue, and enlarged lymph nodes. Because it's a systemic disease, there can also be more specific symptoms depending on which part of the body is affected. If the lungs are affected, it can cause shortness of breath, coughing, and hypoxemia. If the skin is involved, it can lead to nodules called erythema nodosum. This is very high yield, so remember that they typically develop on the lower legs along the tibia. These nodules are caused by inflammation of fat within the skin layer, and they're red, hard, and painful. Another possible skin lesion is lupus pernio, which refers to red to purple skin lesions on the face, resembling those found in lupus. When the eye is involved, sarcoidosis can also cause uveitis, which is inflammation in the pigmented layer of the eye beneath the cornea and sclera. The heart can also be affected, leading to restrictive or dilated cardiomyopathy. When the joints are involved, sarcoidosis can cause rheumatoid arthritis-like arthropathy, as suggested by tender, warm, swollen joints with limited mobility. Another high-yield fact to remember is that in many granulomatous diseases, especially in sarcoidosis, individuals can also develop hypercalcemia due to the enzyme 1-alpha hydroxylase being released by alveolar macrophages. The enzyme converts the vitamin D precursor to its active form, called calcitriol, which in turn increases intestinal absorption of calcium and bone resorption, causing hypercalcemia. Some signs of hypercalcemia include diminished deep tendon reflexes, skeletal muscle weakness, and in some cases, depression and stupor. The liver is also involved in up to 75% of individuals with sarcoidosis, and this may present with hepatomegaly, abdominal pain, cirrhosis or cholestatic liver disease with jaundice. And finally, the condition can affect the brain, causing neurosarcoidosis. The most important sign of neurosarcoidosis is Bell's palsy, a type of facial paralysis that makes it impossible to control the facial muscles on the affected side. This can manifest as muscle twitching, weakness, or total loss of the ability to move one side of the face. Besides a restrictive pattern on PFTs, sarcoidosis diagnosis also includes a chest X-ray or CT scan. The most common findings on both tests and in real life are bilateral hilar or mediastinal lymphadenopathy and coarse reticular opacities due to interstitial infiltration by inflammatory cells. And as the condition evolves, a honeycombing pattern, usually in the upper lobes. Blood tests might reveal high levels of calcium and an increased level of angiotensin-converting enzyme, or ACE, which is produced by T cells. Another helpful clue is finding an elevated CD4 positive to CD8 positive ratio in the fluid obtained by bronchoalveolar lavage. In that procedure, a bronchoscope is passed through the mouth or nose and into the lungs, where fluid is squirted out, recollected, and examined. The ratio increases because the immune reaction causes CD4 positive T cells to accumulate in the interstitium and alveoli, whereas the CD8 positive T cell count stays the same. One final thing to know about sarcoidosis is that a transesophageal lung biopsy showing scattered, non-caseating granulomas might be needed to confirm the diagnosis. Needle biopsy of the liver can also be used to check for the presence of scattered, non-caseating granulomas. Most people with sarcoidosis don't usually need treatment because symptoms resolve spontaneously within a few weeks, with complete remission occurring within a few years. But if there are severe symptoms, steroids can help control the inflammatory response. Okay, next up we have hypersensitivity pneumonitis, which is when an inhaled antigen causes an excessive immune reaction in the lung. It can be caused by many organic antigens, from coffee bean dust, to moldy sugarcane, to bacterial spores in the mist from hot tubs. And the resulting disease is often named for the profession at risk. For instance, the farmer's lung is caused by the spores of actinomycetes that live in moist, newly harvested hay. Malt worker's lung is from aspergillus spores from moldy barley. Pigeon breeder's lung is caused by breathing in proteins from bird poop or feathers, but other animal proteins can also cause the disease. Now, unlike most granulomatous diseases, hypersensitivity pneumonitis can trigger both a type 3 hypersensitivity reaction, in which case it's acute, and a type 4 hypersensitivity reaction, in which case it's chronic. Basically, once antigen reaches the alveoli, it is picked up by dendritic cells or alveolar macrophages, which take it to the nearest lymph node where they present it to Th1 cells. Th1 cells then activate B cells to produce immunoglobulin G antibodies that go into the bloodstream where they meet the antigens that cross over from the alveoli and form immune complexes. This leads to acute hypersensitivity pneumonitis, which is a type 3 hypersensitivity reaction and is immune complex mediated. Specifically, these complexes then get deposited in the basement membrane of the pulmonary capillaries, activating the complement system and attracting neutrophils to the site. Neutrophils degranulate, meaning they dump lysosomal enzymes and reactive oxygen species into the area, leading to inflammation and necrosis of the capillaries as well as nearby alveoli. If exposure to the trigger continues, or if the acute response is unsuccessful, it leads to chronic hypersensitivity pneumonitis, which is a type 4 hypersensitivity reaction with granuloma formation. The signs and symptoms of acute hypersensitivity pneumonitis include fever, shortness of breath, cough, chest tightness, and headache, which typically develop within hours after exposure and resolve gradually within 12 hours to several days following exposure removal. Chronic hypersensitivity pneumonitis has an insidious onset, meaning symptoms develop slowly and worsen over months to years. Eventually, this leads to sustained shortness of breath and, in severe cases, respiratory failure. Besides a restrictive pattern on PFTs, diagnosis is based on a chest X-ray, or CT, showing numerous poorly defined small opacities throughout both lungs, sometimes with sparing of the apices and base. Occasionally, ground glass opacification, which is an area of increased opacity with preserved bronchial and vascular markings, can be the predominant or only finding. A bronchoalveolar lavage might reveal a high number of lymphocytes and mast cells in the lavage fluid. A lung biopsy can also be performed, and it can show non-caseating granulomas around the bronchioles and lymphocyte infiltration in the alveolar walls. Lastly, diagnosis involves identification of the environmental trigger via an inhalation challenge, which is when a person is exposed to the possible trigger and monitored to see if they develop symptoms. Because the condition is reversible in early stages if the stimulus is avoided, treatment consists of eliminating the cause, either by avoiding the environment, altering the environment, or wearing personal protective equipment. Steroids can be used to help with symptoms, but they don't help deal with the underlying issue. The second category consists of pneumoconiosis, which are diseases caused or made worse by the particles a person is exposed to within the workplace, like asbestos and silica or coal dust. Now keep in mind that normally, alveolar macrophages protect the alveoli by eating all foreign particles under 2 micrometers that reach them by a process called phagocytosis. In pneumoconiosis, macrophages fail to eat these inhaled particles because they are hard to digest or toxic. This causes some of them to die, activating the remaining macrophages, which start to release inflammatory cytokines and growth factors. Cytokines damage the lungs and cause inflammation, attracting even more macrophages and fibroblasts that proliferate and synthesize collagen in order to control the damage. In time, if the inflammatory response persists, the collagen released by fibroblasts into the interstitial spaces hardens, resulting in scar tissue that causes alveolar walls to thicken. So remember that unlike the previous 2 disorders, pneumoconiosis is not always associated with a hypersensitivity reaction. Pneumoconiosis can also increase the risk of Kaplan syndrome, which is a combination of rheumatoid arthritis and pneumoconiosis with intrapulmonary nodules. This is most likely due to rheumatoid arthritis' tendency to alter how a person's immune system responds to foreign materials. For the causative agents, asbestos belongs to a family of minerals called silicates, typically used as materials in shipbuilding, plumbing, roofing, and the textile industry. The risk of getting the disease depends on the duration and intensity of exposure and the type, length, and thickness of inhaled fibers. Actually, you should know that people exposed to asbestos also have a high risk of mesothelioma, which is a type of aggressive cancer that originates from the mesothelium, which is a thin membrane made of epithelial cells that lines the pleural cavity. A high-yield concept to keep in mind is that they have an even higher risk of bronchogenic carcinoma. Asbestosis is initially asymptomatic, but can sometimes cause progressive dyspnea, non-productive cough, and fatigue. Advanced asbestosis may cause hypoxemia, nail clubbing, dry crackles at the base of both lungs, and in severe cases, symptoms of cor pulmonale like chest pain, tachypnea, and exertional dyspnea. Diagnosis is based on a history of exposure to asbestos, a restrictive pattern on PFTs, and chest X-ray or high-resolution CT, which might show reticular bilateral opacities in the lower lobes. This can be remembered by the mnemonic, asbestos is from the roof, because asbestos was common in insulation, but affects the base, which means lower lobes of the lungs. If pleura is affected, exudative effusion and pleural plaques with calcification are also common. Pleural plaques are areas of the pleura that are thickened by collagen deposits, and more importantly, virtually pathognomonic of exposure to asbestos. On an X-ray, they are seen as opacities that present the incomplete border sign, which is when the inner margin of the opacity is well defined because it is tangential to the X-ray beam, but the outer margin is barely visible. On a sputum sample obtained by bronchoalveolar lavage and colored using a Prussian blue stain, asbestos bodies, also called ferruginous bodies, are seen as golden brown, fusiform rods, or as having a dumbbell shape with multiple segmentations. No specific treatment exists. Early detection of complications like hypoxemia and right ventricular failure is vital, while pulmonary rehabilitation, consisting of exercise training, health education, and breathing techniques can be helpful in reducing symptom severity. The next type of pneumoconiosis is silicosis. This condition is characterized by nodular pulmonary fibrosis secondary to inhalation of silica dust. Silica dust, more specifically crystalline silica, is found in rocks, sand, gravel, and clay, which is why silicosis is associated with those who work in sandblasting, foundries, and mines. Moving on, there are two high-yield particularities to note regarding its pathophysiology. First, silica is thought to disrupt the macrophage phagolysosome, impairing the macrophage's killing ability. It's important to remember that defense against mycobacteria, the bacteria that causes tuberculosis, is especially impaired. So individuals with silicosis are more susceptible to developing tuberculosis. And second, when the silica-containing macrophages die, they release silica particles into the interstitial tissue around the small bronchioles, causing the formation of the pathognomonic silicotic nodules. These nodules initially contain inflammatory cells and fibroblasts, dense patches of collagen fibers, and scattered birefringent particles of silica dust. As the nodules mature, their center becomes a dense ball of fibrotic scar with a classic onion skin appearance, which is surrounded by an outer layer of inflammatory cells. If exposure is terminated, the nodules don't evolve or compromise lung function, but if it persists, the nodules merge together and cause progressive fibrosis. Silicosis initially causes mild dyspnea on exertion, but as fibrosis progresses, it can lead to severe dyspnea, hypoxemia, pulmonary hypertension, and respiratory impairment. Diagnosis is based on a history of silica exposure, a restrictive pattern on PFTs, and chest X-ray or CT findings. The most common findings are nodular opacities in both lungs and the classic eggshell calcification of hilar lymph nodes, usually affecting the upper lobes. This can be remembered by the mnemonic, silica is from the base or the earth, but it affects the roof, which are the upper lobes. A node biopsy can confirm the diagnosis by showing birefringent particles of silica surrounded by fibrosis. No effective treatment exists except supportive care and, for severe cases, lung transplantation. Next, chronic berylliosis is both a chronic occupational and granulomatous lung disease, characterized by systemic, non-caseating granulomas caused by beryllium exposure. Chronic berylliosis is often the result of repeated exposure to beryllium, and it is distinct from acute beryllium poisoning, which became rare following occupational exposure limits. Now, beryllium is a metal that is used in aerospace and manufacturing industry for items like cars, computers, golf clubs, and electrical equipment. The metal itself is safe, but the beryllium dust or fumes that result from its processing is highly toxic. In those susceptible, the substance triggers a type 4 hypersensitivity reaction with mononuclear cell infiltrates and non-caseating granuloma formation in the organs where beryllium has deposited, especially the lungs, intrathoracic lymph nodes, and skin. In some, after the initial exposure, the lungs can actually become sensitized to beryllium, and they will be asymptomatic. In others, symptoms may develop within months of first exposure or even 30 years after exposure has ceased. Typically, these consist of progressive dyspnea, cough, and fatigue. Some people can also lose weight and have night sweats. Diagnosis includes a history of beryllium exposure, a restrictive pattern on PFTs, and establishing beryllium sensitivity using the beryllium lymphocyte proliferation test. The test uses peripheral blood or fluid from a bronchoalveolar lavage and lymphocytes cultured with beryllium sulfate. Cells are then counted, and those with an elevated number of cells are considered abnormal. Chest X-ray and CT can detect nonspecific signs like nodular opacities in the mid and upper lung zones, frequently with hilar and mediastinal adenopathy. There is no cure for berylliosis. However, there are nonspecific approaches that can reduce symptoms and slow the progression of disease. These include stopping exposure to the substance, giving supplemental oxygen and oral corticosteroids in those with acute symptoms, and pulmonary rehabilitation. And lastly, coal workers' pneumoconiosis, or CWP, also known as black lung disease or coal miners' lungs, is characterized by lung damage caused by exposure to coal dust. The condition is common in coal miners who develop the disease after being exposed to coal dust for more than 20 years. Air pollution particles can also lead to a similar but asymptomatic condition called anthracosis, which is typically found in many urban dwellers exposed to sooty air. Now, something specific to CWP is that as macrophages eat up the inhaled coal, they become laden with carbon and form 1 to 2 millimeters nodular aggregations supported by a fine collagen network called coal macules. These structures are the pathognomonic feature of CWP and tend to occur around the initial site of coal dust accumulation, which is the upper regions of the lungs, around respiratory bronchioles. Because they cause pulmonary inflammation, they are also surrounded by focal emphysema, which develops as bronchiole walls weaken and dilate. Fibrosis can occur, but is usually limited to areas adjacent to coal macules. In severe cases, the macules can merge to form coal nodules, which they themselves can coalesce to form black, rubbery, parenchymal masses, usually in the upper posterior lung fields. CWP does not usually cause symptoms. Most chronic pulmonary symptoms in coal miners, like cough, dyspnea, and chest pain, are caused by other conditions such as industrial bronchitis due to coal dust or coincident emphysema due to smoking. Diagnosis is based on a history of coal exposure, a restrictive pattern on PFTs, and a chest X-ray showing small, rounded nodular opacities, typically affecting the upper lobes. Treatment is generally supportive, the most important part being limiting exposure to coal dust and pulmonary rehabilitation. And the final category belongs to miscellaneous causes of restrictive lung disease. Now, there's a lot to talk about here, but the bottom line is that many systemic diseases, like rheumatoid arthritis, granulomatosis with polyangiitis, Goodpasture syndrome, and pulmonary Langerhans cell histiocytosis, can cause lung damage, resulting in pulmonary fibrosis by a variety of mechanisms. Drugs like the antiarrhythmic amiodarone, the antibiotic nitrofurantoin, or chemotherapeutic agents like methotrexate, bleomycin, and busulfan can also result in pulmonary fibrosis, with symptoms similar to those of the rest of DPLDs. Moving on to restrictive lung diseases without a known cause. Idiopathic pulmonary fibrosis is characterized by repeated cycles of lung injury and healing, resulting in excess scar tissue in the interstitial tissue of the lung. Now, the most important thing to note is that the trigger is unknown, and that the condition usually presents in individuals with no history of pulmonary diseases. However, there are some known risk factors, including old age, male, and tobacco smoking. Once the process starts, the fundamental problem is that type 2 pneumocytes overproliferate. Type 2 pneumocytes line the alveolar wall, along with type 1 pneumocytes. They secrete surfactant and have the unique ability to proliferate whenever the alveoli are injured. Myofibroblasts, which are cells that secrete collagen, overproliferate too. And to make matters worse, they don't undergo apoptosis, as they should, at the end of the repair process. Instead, they continue to make even more collagen. And as collagen accumulates and hardens, it causes the lungs to stiffen and the respiratory membrane to thicken, leading to the changes seen in DPLDs. Another complication that can occur is traction bronchiectasis, which is irreversible dilation of bronchi and bronchioles caused by fibrosis pulling apart the surrounding parenchyma. Individuals are usually asymptomatic in the early stages, but because idiopathic pulmonary fibrosis is a progressive process, they can quickly develop symptoms that impair normal daily activities. Problems with oxygenation and ventilation can cause dry coughing and shortness of breath, as well as cyanosis and digital clubbing. Over time, it can lead to significant respiratory failure as more of the healthy functional tissue is lost. Diagnosis of idiopathic pulmonary fibrosis can be made using PFTs, which can show signs of restrictive lung disease, and chest CT, where the most common finding is the honeycomb pattern associated with pulmonary fibrosis. Diagnosis can be confirmed by lung biopsy, showing dense fibrosis, fibroblast proliferation, and cyst formation. In order to diagnose idiopathic pulmonary fibrosis, it's necessary to first rule out other potential causes of pulmonary fibrosis. Treatment options include supplemental oxygen and antifibrotic medications, which generally slow the progression of the disease rather than stopping it. Unfortunately, the only definitive treatment available currently for severe situations is a lung transplant. And to conclude, extrapulmonary restrictive lung diseases are those conditions that interfere with the structures involved in the breathing mechanisms. Because the lungs are healthy, both the diffusing capacity and AA gradient are normal, but the volume changes seen in the other restrictive pulmonary diseases are present. Now we can divide the extrapulmonary causes into two main categories. First are the ones that cause weakness of the respiratory muscles. These include polio, myasthenia gravis, Guillain-Barré syndrome. And second, there are those characterized by structural abnormalities, like scoliosis and morbid obesity. These impair inhalation by acting as an obstacle in lung expansion, causing a decrease in inhalation lung volumes. Another example of this would be ankylosing spondylitis, a type of arthritis affecting the spine, which restricts pulmonary expansion by causing fusion of the costovertebral joints and ankylosis of the thoracic spine, or by anterior chest wall involvement. Symptoms depend on the underlying pathology, but most individuals tend to present with short, shallow breaths and pain while inhaling. Diagnosis is based on the clinical picture, PFTs, chest X-ray and CT, and specific diagnostic test for whatever is suspected of causing the ventilatory problem. All right, as a quick recap, restrictive lung diseases are marked by impaired inhalation, which causes a decrease in forced vital capacity, residual volume, total lung capacity, and functional residual capacity. The causes of restrictive lung disease can be divided into diffuse parenchymal lung diseases and extrapulmonary lung disease. DPLDs include sarcoidosis, a systemic autoimmune disease common in African American females, hypersensitivity pneumonitis, which is a type 3 and type 4 hypersensitivity reaction due to an inhaled antigen, pneumoconiosis, which includes asbestosis, silicosis, chronic berylliosis, and coal-workers' pneumoconiosis, where inhaled toxic particles can't be broken down by macrophages, leading to chronic inflammation and impaired macrophage function. And idiopathic pulmonary fibrosis, which results from increased scarring of the alveoli by an unknown cause. Extrapulmonary lung disease can also have a restrictive pattern, where the lung volumes and capacities are decreased, but diffusion and the AA gradient is normal. Common causes can be due to respiratory muscle weakness, like myasthenia gravis and Guillain-Barré syndrome, or due to structural abnormalities like morbid obesity and scoliosis. Back to our cases. Alicia presents with progressive shortness of breath and cough, weight loss, and her PFT showed a restrictive pattern. Examination reveals painful, red skin lesions on the sides of her nose and both legs. This is erythema nodosum, which are a classic sign of sarcoidosis. Another clue is that she's a young female of African descent. To confirm the diagnosis, a chest X-ray and biopsy can be done. Next, Richard presents with gradually progressive dyspnea on exertion, non-productive cough, nail clubbing, and his PFT showed a restrictive pattern. Chest X-ray showed honeycombing fibrosis, but that's not specific to any disease. Now, given his unspecific symptoms and the fact that he has no history of underlying pulmonary disease, we suspect he suffers from idiopathic pulmonary disease.